Okay, well, let's call the meeting to order. And I'm Clay Cockrell, Dr. Cockrell from Dallas, Texas. I'm the seminar director. And we're very honored to be hosting the 69th annual Zola Cooper Lee T. Nesbitt Clinical Pathologic Seminar, which is the oldest independent CPC in the world. We have these. Just a couple of things at the beginning. Our guest a couple of years ago was Dr. Marty Mim, who unfortunately passed away earlier this year. And another long-term contributor is Dr. Richard Reed as well, who basically, he passed away a couple of years ago. And then Dr. Nesbitt, who we named the seminar, passed away tragically years ago from a pulmonary embolus. So these are some of the people that we've honored in the seminar. And you can see some of the people that actually have been involved in this really very luminary group. And we're honored this year to have Tony Fernandez from the Cleveland Clinic. I actually knew Willard Steck. He was a good golfer years ago. You can advance those slides on your side, Carlos, too, if you want to. And also I want to thank Dipti Anand, who is sitting next to me. She's the other moderator, and Carlos will be the clinical moderator if you'll advance the slides over there, Carlos Riccati. Catch up to me over here. I want to thank our supporters. We work on this. This is our laboratory, but the guy that really gets the credit is Chris Bandel, who's sitting there in the back. He basically is a left ventricle that helped put all this together. Really appreciate his work. And Castle Biosciences has really been a godsend for us. Matt Goldberg, Carrie Damon in the audience here, really appreciate everything. These two beautiful images in this projector that you see here are because of the educational grant that they gave us this year. So we have a really nice video for you guys this year. So without any further ado, I think we should begin and start off with the first case. We got a lot of cases this year, and we got to get through it by 12 noon. So Dr. Riccati.
Okay, hi, how is everyone? This is a 63-year-old woman with no personal history of breast cancer or any change. She has a new changing lesion in the axilla. You could see here that's a black pen mark surrounding the lesion, but in the center there you can appreciate pink scaly papules, which were eventually biopsied.
The histology of this lesion, as you can show, that it sees, you can see this intraepidermal proliferation of single and nest of, you see this intraepidermal proliferation of the single and nest of malignant appearing cells exhibiting a marked pagetoid growth pattern with interlentiginous involvement. And when you go on high power, you can clearly see that there is some pigment, but these are not melanocytes. You can appreciate the foamy mucinous cytoplasm, eccentric nuclei. So that's a pagetoid growth pattern of an adenocarcinoma, and this was supported by immunostains. These tumor cells were negative for SOX10, which is a melanocytic marker, and positive for pancytokeratin, as you can see off in the next stain, as well as for CK7. This would be consistent with the intraepidermal epidermotropic metastasis of an adenocarcinoma, which was in the axilla, so it would be extramammary Paget's disease.
The patient had no history she had imaging of the breast. Those were clear. They did have imaging of the lymph nodes. They did show multiple lymph nodes that were positive on PET scan and MRI. So I don't know.
We always have our moderator ask the guest if he has final comments. If you do, or you don't have to comment on the case. But I thought it was kind of interesting because this was sort of extramammary in a way, because it was the axillary tail of the breast, that auxiliary tail of the breast that actually was associated with this cancer.
I think we go to the next case. This case is also from Dallas as well as Oklahoma. This was a 73-year-old man presented with lesion on the left nipple. You could see here, areola. There's a pink eroded papule that had been present for some time, and it started expanding in size, and the lesion was subsequently biopsied. The patient really didn't have any pertinent history to this particular lesion, and it was biopsied.
And as you can see, the biopsy shows us clearly malignant tumor, and there are these infiltrating expansile nests and cords of epithelial cells which are filling and expanding the reticular dermis, markedly atypical, again, containing this moderate to abundant amounts of eosinophilic cytoplasm, prominent nucleoli. And this at this site would be very, very consistent with a breast adenocarcinoma. This was an interesting case of a primary cutaneous mammary carcinoma in a male.
There was a little bit of a discussion on that yesterday, one in which there's a raising incidence, as Dr. Cockrell had mentioned, in men. And then I had later on brought this up, and I don't know if you have additional comments about.
Yeah, in males, I think one thing you have to remember is if male breast cancer is associated with an increased risk of BRCA2 gene mutation. So when you see a man with breast cancer, you want to think about offering that testing, which can be important, of course, for the other family members.
In addition, I don't know if Travis we were talking also, some of these cases that are metastatic breast, the breast oncologist require or request a lot of additional staining, including fish. Goes a little bit beyond sometimes dermatopathology. There is some subjectivity to doing that. A lot of us dermatopathologists send these out for breast consultation to breast pathologists. And I think, I don't know if Travis would like to, or Dr. Vandergriff would like to mention if you think.
For consultation to a breast pathologist, because the treating clinicians need a report with a panel of markers to guide their treatment choices. And even if the patient's already had those tests done on prior biopsies, it can change over the course of the disease. So they want the most recent information they can have. So I always involve a breast pathologist with you.
So this was went out primary cutaneous breast carcinoma in a male. This next case out of New Orleans. This is a 65-year-old woman with a lesion on the chest. She had a previous history of adenocarcinoma of the lung. She had multiple metastases, including to the brain. She presented with this lesion after being followed since 2018, which was subsequently biopsied.
As you can see, the histology clearly shows an infiltrating malignant epithelial neoplasm. And you can see these infiltrating nests and again cords of these malignant epithelial cells with marked atopy and
Not that one,
pleomorphism,
Brian. Nope. The other one.
hypochromasia. And given the history of lung adenocarcinoma, this tumor was stained up. It was positive for TTF1, as we know is a marker for a lung adenocarcinoma, and was also CK20 positive. So the histology would be consistent with metastatic cutaneous adenocarcinoma from a lung origin.
This one, this patient did receive in 2018. She did receive in 2018 radiotherapy as well as chemotherapy for her breast cancer. Was also currently on CPI for her metastatic. They discontinued it and they went back to chemotherapy. I don't know if there was any additional comments, the panelists, the dermpath panelists, or Dr. Fernandez or Dr. Cockrell like that.
No, I mean, I think, every dermatopathologist, of course, gets these biopsies. It's never a fun diagnosis to render a metastatic carcinoma, but, we get them.
And I think as a dermatopathologist, it's excellent if that information is included on the clinical requisition sheet, because, we don't want to do $1 million workup when we know that the patient already has metastatic lung cancer. But unfortunately, it's often forgotten to include that. So it would be nice to just get that pertinent history.
As a 19-year-old man with a history of recessive dystrophic epidermolysis bullosa, you could see here he developed a lesion over the right leg over some time. Initially, they were treating it as an infectious process. It was eventually biopsied, and you can see there the biopsy.
The biopsy clearly shows a malignant squamous tumor. You can see this markedly atypical cells with clear squamous differentiation. There is dyskeratosis, intercellular bridges, keratin pearls. So this would be consistent with an invasive, this was classified as a moderately differentiated squamous cell carcinoma. And it's just a classic invasive squamous cell carcinoma.
They did do imaging. Again, this patient presented with multiple lymphadenopathy. At this time, she was being looked at for palliative radiation with pembrolizumab in combination. Obviously, this is, as we discussed yesterday, these patients tend to die from squamous cell carcinomas. I don't know if there was additional information that the panelists would like to add.
I think, recessive dystrophic EB it's a horrible disease. As you mentioned, squamous cell carcinoma first of all, arising in a scar can be quite aggressive. It's what usually kills these patients. So anytime I think you see an ulcer that's sticking around for more than a short period of time, you need a biopsy.
That's a really good point. You know, if it's an ulcer that isn't healing, just remember the differential diagnosis includes neoplasia, not just inflammatory ulcers. So it's just, yeah, obviously didn't think of the cancer here when they originally saw it.
Case number 5. This is a 65-year-old man with bilateral lower extremity venous insufficiency, presents with this verrucous polypoid nodule on the first right toe. You can see there's a verrucous change on the surface of the epithelium. Patient also has background lymphedema changes, secondary to the patient's lymphedema, venous cases, I'm sorry.
This is obviously one of those cases where, the clinical looks, pretty impressive. The histology kind of corresponds to it. You can see the verrucous epithelial reactive hyperplasia. And in the dermis, the scar-like proliferation of relatively bland appearing fibrohistiocytic cells. There is accompanying lymphoplasmacytic inflammation, some interstitial hemorrhage with hemosiderin deposition, which would correspond with the histology, some interstitial edema. But overall, a pretty bland cytomorphology of these fibrohistiocytic cells. Obviously, given that this was initially just a biopsy of a portion of this lesion, which clinically looked pretty impressive, and on subsequent imaging studies, one could also see osteolysis. A complete excision was recommended because we do not want to miss aggressive tumors, especially tumors like cellular or hypocellular variants of DFSP or superficial acral fibromyxomas at this site. And fortunately enough for the patient, the excision specimen was also showed benign reactive fibrohistiocytic scar-like proliferation. So, we really believe that this is likely all reactive in nature. You can again see this fibrosis with reactive stromal fibromucinous changes, some lymphocytic inflammation. And, so this is not a spindle cell tumor. You have relatively excluded that out, but consistent with edema and, other reactive changes occurring at this site.
Yeah, I don't know if any of the presenters are here, but if any of you guys want to comment on cases, if you know the case and the sort of what's happened with the patients, you're welcome to do that. We were very impressed with the clinical, but the pathology, we think it's probably analogous to all the lymphedema that the patient got.
Patient is not professionally involved with this. I saw her in clinic one time and she showed me the biopsy. I do derm-path. So I told her, this is like, it doesn't make a lot of sense. It's just reactive. We really need to take the whole thing out. So we sent her to ortho and they did the full excision. And it seems the read was consistent with eccrine angiomatous hamartoma, but I really didn't see much of vessels around these eccrine glands. So I don't really think this is a correct diagnosis. I was glad this is more benign because we were worried this might be like more. And now looking back, are we thinking this could be in the word of like elephantiasis, kind of like more like lymphedema reactive, and that's why we have these verrucous changes? I
think that's what we think.
Okay, that's good. Thank you.
The unusual thing seems to be the associated osteolysis, and is that really directly related to that lesion or something?
Yeah, that's interesting. And I don't know, Dr. Marina, you saw her also in clinic, and I don't know if she had like any infection underlying. It was a really odd case, and we were happy to present it today.
So just to mention, some osteolysis noted on radiographic imaging underlying this lesion of the bone.
So this patient is schizophrenic, and so she has been in the care of her sister, and so apparently wore shoes that didn't allow anyone to detect this for a very long time. So we don't really have a lot of history to help us here. We just saw this growth from the first digit and with a lot of lymphedema, and we don't really know why. So it's just very interesting. I can't connect the osteolysis at all to the tumor itself. But we were glad to hear that it's benign and that she doesn't need any other, but this has been neglected for several years. I can just tell you that for sure.
So in the end, our final diagnosis is a reactive changes secondary to extensive lymphedema and venous insufficiency rather than a true neoplastic process. malignant neoplastic process. Case number 6 comes out of San Diego, California. This is a 43-year-old man with a 5-month history of this lesion on the left arm. You can appreciate that there's a pink ulcerated papule with a somewhat colorative scale that was biopsied.
So this is really one of those cases which is dermatopathology fun when it comes across your microscope. And you can see this kind of a well-circumscribed tumor with this nice epidermal collarette. And when you go on high power, the tumor is composed of cellular proliferation of cells, which obviously have eosinophilic but very clear cytoplasm present in a perivascular distribution. So fortunately enough, if you have seen this tumor, you'll always remember it. It's one of those entities which is rare, but it can occur in the skin. And the immunophenotype is pretty diagnostic. So this is probably one of those rare skin cell tumors that stains with 2 markers, which is one is the muscle marker. Caldesmone is a muscle marker, so strongly positive for that. And also positive for a melanocytic marker, which is MITF. So with this kind of a dual staining, it's pretty slam dunk diagnosis with that histology, which is a cutaneous sarcoma, perivascular epithelioid cell tumor, which is much more common in visceral sites and occurs in the spectrum of tumors of clear cell sugar tumors of the lung and adenomyolipomas in patients with tuberous sclerosis. And that association has not been described in the skin lesions. And, but it makes a great case. The lesion is completely excised. And, that if not, then we would recommend that. It had some focal staining with HMB45 as well.
So these lesions somewhat can be subtle as far as whether they're malignant or not. There's probably some overlap. I think as panelists as a whole, we were reassured by the pathological findings overall, and that it's completely removed. There were some imaging studies just because it was initially signed out as malignant, and those were all clear for metastatic disease. Case number 7, it's out of Dallas. This is an interesting case. A 69-year-old veterinarian man who had a lesion on the arm, who had received some liquid nitrogen from a colleague and had been treating it over the years for who knows what. And it persisted, the lesion. Eventually, the patient did get a biopsy and from his dermatologist.
Yeah, this guy was a veterinarian, and actually he lived up in North Carolina, and he did. He was a retired veterinarian, and he got some liquid nitrogen from one of his actively practicing colleagues and started treating this himself. And we don't know what it looked like originally, but we do know that liquid nitrogen is toxic to melanocytes, and it's possible that it may have been a pigment lesion at first, but there you see it's just kind of a pinkish area, and the clinician was not suspecting melanoma here when he took a biopsy of it.
And, when you see the biopsy, it's a classic melanoma in situ. You see this asymmetrically distributed single and nest of melanocytes varying in size and shape. There is interlentiginous involvement, palatal extension, cytologic atypia. So it's pretty classic melanoma in situ. You can see these tumor cells, which do not look healthy at all. And the lesion went subsequent excision. And this was, stresses out the point over here that the original biopsy was a melanoma in situ, but you can see with the wound of a previous procedure, there is an invasive nodular melanoma, which is in fact going deep into the reticular dermis and the fat. It's Clark's level 5, and you can even see foci of perineural invasion. So this was a breast floor thickness 5.5 millimeter level 5 invasive melanoma, stage 4A, and you can see that it's minimally pigmented. So one of those amelanotic variants of, nodular melanoma with minimal pigmentation and, kind of like an aggressive growth pattern.
The patient did have ipsilateral lymph node involvement, and in Florida, we see a lot of pink patches that come back as melanoma. I don't know if you guys want to comment on that, because sometimes we treat it, but
Well, to me, when I look at this lesion, it's not that impressive clinically. I can imagine some people might look at that and just say, well, just leave it alone, put some mupirocin on it, leave it alone, it'll heal. And I think to me, the lesson here is when somebody comes in with something that's non-healing, or especially when they're trying to do things at home themselves, you should have a very low threshold to biopsy and just make sure you know what's going on.
I think that really holds true in these southern states, Louisiana, Florida, Texas, especially. Anywhere, Ohio too. Ohio as well. Ohio as well. Case number 8 is an 81-year-old man who presents with this nodule on the arm for a few months that was expanding. It was subsequently, you could see here, it's pretty nondescript nodule on the right arm with some faint pink erythema overlying. Then pathology.
And, again, this is a great teaching point for the dermatopathologists in general. Whenever you see a spindle cell proliferation with this asymmetrically distributed lymphoid aggregate, and you can see this kind of a trailing lymphoid aggregate at this end, no matter how bland and banal it looks, you should worry about a desmoplastic melanoma, especially with the kind of a clinical presentation. And this is exactly what it is. So the worrisome signs are those asymmetric lymphoid aggregates, the trailing lymphoid aggregates. And you can see that it has a very neurofibroma-like look to it with these kind of neuroid wavy spindle cells. But with that kind of morphology, you would worry about a desmoplastic melanoma. And that's exactly what this entity is, positive for S100 as well as SOX10. If you look on careful examination, there are pleomorphic appearing cells. So this is an invasive desmoplastic melanoma.
Just for the residents, so you guys know both SOX10 and S100 protein will be positive in neurofibromas. And I think the point here, as Dipti is mentioning, you get a diagnosis as neurofibroma, you have a clinical like that. Really, it's up to you to kind of say, well, it doesn't look like a neurofibroma definitively. I think we spoke yesterday about some distinguishing markers. I don't know if you guys want to mention that help us.
Yes, so P53, which is a tumor suppressor gene, is positive in these tumors, and so is also NF1, I believe. Is that correct? Yes, and that can be useful. And one of the really useful stain which I find helpful is CD34 as well. CD34 in neurofibroma shows a classic finger positivity, finger pattern staining, which is kind of disrupted in desmoplastic melanoma. So that's something can also be used, but it is a challenging diagnosis.
From a clinical perspective, I've seen now about 9 or 10 of these from really good, high quality, well-trained dermatologists submitted as cysts. So beware of the diagnosis of cyst. And don't be surprised. Sometimes you biopsy one of these and it comes back as desmoplastic melanoma.
Next case, this is case number 9 out of Florida and New York. This was an 84-year-old man who has this lesion on the left chest. You could see on the right from your left, a asymmetrical, pigmented, somewhat scaly papule. On the right, you see the dermoscopy, and the concerning aspects were the asymmetry, structureless areas around 1, 2 o'clock, as well as around 7 o'clock. And there were some gray dot granules present, which this picture, hard to see them. But if Harold says it was there, then they're there, Dr. Rabinovich. But those kind of structureless areas with gray dot granule suggestive features of possible melanocytic malignancy with possibly even some regression. There was pathology done on this.
So again, this is a great case because it illustrates the importance of, sometimes occasionally when lesions are partially sampled, there can be a discorrelation on clinical and pathology. And it's a great case demonstrating that. If you guys are clinically concerned about something, do communicate that reliably with your clinician. The pathology here, maybe because it was a portion of the lesion, does not show features which are very reflective of the clinical appearance. Shows features more consistent with the dysplastic knee where there is not a whole lot of interlentiginous involvement. Some clues could be this kind of asymmetric, again, patchy lichenoid inflammation. But again, overall, this would be more on the histology, be like, okay, it's a dysplastic knee, was not really a melanoma. However, because the clinicians were really worried, they did pursue the 23 gene expression profile, the MyPath test, which was fluidly positive, which is, consistent with the clinical presentation in this patient of a melanoma in situ. And this is the confocal examination, which I think I'll look at.
Yeah, so I'm a novice at this, but I have some experience because I know Harold. But when I was reading his comments, pretty much there on the left-hand side, you'll see large dendritic melanocytes, and those tend to be more towards what would be considered a malignant process. This asymmetrical or atypical honeycomb pattern, which I guess if you compared it to normal, it would be a little bit better to appreciate. But that's what their concern was. So I think that this highlights sometimes the importance of trying to, with all the new information that we have, molecular technologies that we have, sometimes the clinical and path don't fit, and we have new tools. And so that's kind of my take on this. And I think the next case is very similar. I don't know if the panelists would like to add anything to that.
We'll just do the next case and discuss them a little bit together, maybe.
The next case is case 10. This was on a 38-year-old woman on the thigh. You can see on the thigh on the left hand side, you see asymmetrical brown. Some areas have pink papule. On the right hand, the dermoscopy. Some of the features are very characteristic of this here, these pseudopods, very characteristic of a Spitz nevus. They're called the pseudopods there. Does have a globular network. There was some concern due to the structureless and asymmetrical areas here, and this was subsequently excised for evaluation.
Yes, and the excision specimen does show features which again correspond with the Spitzoid appearance of the lesion, which is kind of like pigmented, so pigmented Spitzoid variant. And you can see this, it's heavily pigmented, but overall, Spitzoid appearing cells with not much interlentiginous involvement. And again, the gene expression profile testing was done on this. It was consistent with the clinical and the path appearance of a benign lesion. It was completely in the negative range, which would be consistent with the diagnosis of a Spitz nevus.
Yeah, it's got kind of funny morphology up there between like around 12 and 3 o'clock. That's totally circumscribed. And so I think anyone that would see this would take a biopsy of that and be concerned about it. And I think if we saw that coupled with histology, I think I would certainly recommend re-excision. Just when you take a shave biopsy or a punch out of one of these things, you're only looking at a very small lesion. And the gene expression profile is reassuring, but even that, possibly, sometimes we see lesions that are actually malignant that come back with a negative result. So the clinical of that thing is really, especially the dermoscopy view, is concerning off to the right there. We have an image over here on the if people advance it that shows the confocal.
There was a brief comment yesterday about BRAF utilizing for Spitz nevi versus melanocytic malignancies. I don't know if you want to bring that up, Dr. Hernandez.
Yeah, our group, we have BRAF, B600E immunohistochemistry, and we commonly use that in challenging Spitzoid lesions to help us determine whether we think it's really malignant versus benign. We find it helpful. I think there are other groups that find it helpful. So it may be something that becomes more common that you see in reports in the future.
I don't think it's definitive. I think what's happening is I mean, these guys, UCSF, PEDRAM, they're really expanding this knowledge base based on the Spitz tumors. And, we were talking today about ALK Spitz nevi and stuff. But I do believe it's kind of like a stain that we have that could kind of either lead us towards a Spitz nevus, or if we need to further work it up and go further down to melanoma. Again, you and Dr. Cockrell have been around with all these things for so many years. And it's like, well, what if it's positive? What if it's negative? This is, I learn from you guys every day where it's like, that's not always the case because new stains have been coming out for as long as you guys have been practicing. And sometimes it's helpful and sometimes it's not. In the end, you got to look at clinical, you got to look at the path, and there may be some ancillary information or additional information such as CAS or other.
Well, the other thing is we really don't know if you look at a lesion like that, there might be some small foci that may be, genetically abnormal. And if you left it alone for another 20 years, it might turn into obvious melanoma, or the host might just keep it in check and it never does anything. So I think now that we're looking at these things in more sophisticated ways, there's information there and we're not 100% sure what it means. But certainly reassuring when you get something like this back that's benign.
I think overall, Charlie, I think we're missing some algorithms, which just because we don't have information yet, all the information to what and how to stain and when. I think a lot of it just shooting stuff, me included, that doing it. And so I think we're missing algorithms that it's based on experience. It's not there yet for everybody. Case number 11. This is a 53-year-old woman with left hand lesion. You could see here, there's a somewhat, it's marked with marker. That's not the lesion actually underlying there. It's a somewhat pink erythematous papule. She does have an underlying history of leukemia treated with radiation in the past, as well as acne and rosacea. This lesion was biopsied.
So this is one lesion where you definitely would require clinical path correlation. And I'm going to describe the histology, which is acral skin, dermal edema, perivascular interstitial lymphohistiocytic infiltrate, and there is obvious interstitial mucin. So this kind of combination of findings is not seen in one, but in different entities. So, you would think about, could this be GA, but then why is there dermal edema? Could this be, according to the protocol, the possibility of histiocytoid variant of sweet syndrome raised, particularly because the patient had a history of leukemia? But again, the mucin would be an unusual finding in it. And the other things that, you could think about is its acral location, acral persistent papillary mucinosis, which is a variant of lichen myxomatosis. But again, dermal edema would be an uncommon finding. Pernio is something which I think finally the group felt it probably is an unusual presentation of that. The dermal edema would fit. But, again, this kind of interstitial lymphohistiocytic infiltrate, you can see mucin in pernio, but the lymphohistiocytic with the absence of the classic perivascular aggregates would again be unusual.
Or just be a reactive process secondary to something, because this was biopsy. She came back 2 weeks later. It's no longer present. So,
It's a good real world example of sometimes, you try to fit it into something sort of just doesn't fit.
yeah, exactly.
Yeah, I think at the end of the day, this is things that on the clinical side and the dermatopathology side, we deal with every day. On the derm path side, we probably sign this out descriptively, maybe give a differential diagnosis. And on the clinical side, maybe topical steroid and then follow the patient and see what happens. And if it's persistent, you may want to rebiopsy. Luckily, it went away.
Case number 12 is a great case because I've never seen it. This is a 69-year-old woman with a history of both breast and colon cancer. And she presented to clinic with this, you could see here on the right first toe, you see this somewhat irregular linear hyperpigmented band on the lateral aspect of the first toenail, as well as I believe this probably, there's a glistening likely from the photograph that's not present on this area of the proximal nail fold, probably a papule that's kind of protruded out. It's kind of like how I'm interpreting it. But however, this lesion here, as you can see, was somewhat concerning. And so this was biopsy.
The real point about that is that there's no Hutchinson sign there too. So you'd think there'd be a Hutchinson sign of melanoma, but that's still a pigmented area of the nail unit. You're going to take a biopsy of that, especially if it's a solitary digit.
The nail unit biopsies can often be very challenging, but however, this is a beautifully done biopsy. You can see there's a portion of nail matrix epithelium here, and there are these free-lying cysts which are close to the overlying surface. There's the epithelium is clearly lacking in over here, but it's close to the surface of the lesion. And what you can see is that these cysts, which appear kind of relatively banal, are lined by this stratified squamous epithelium with no granular cell layer, which is onicolemal in derivation with this onicolemal keratin within the cyst lumen. So the diagnosis here was consistent with a subangual onicolemal cyst, which is analogous to a subangual epidermoid inclusion cyst. However, a very important point to make in conjunction with the histology of this lesion at this site, along with this kind of banal appearing cystic appearance of the lesion, you do not, as a dermatopathologist, want to miss an aggressive digital capillary adenocarcinoma. That's one tumor which is extremely scary, can be looking completely benign on the digit. That's something that should be on the radar of both a clinician and a pathologist.
We were all somewhat concerned. This is not a common lesion. We were reassured just today, got some follow-up, that this was read by one of our previous guest speakers, Dr. Rubin, as this entity on a glioma cyst. Now, Hyperpigmentation of the nail. Obviously, there's many different causes. Onychopapilloma can cause it, trauma. So, great case. Case 13 is out of New Orleans. This is a 77-year-old female presenting with a tongue mass that's been persistent since 2019. That's been slowly growing. She does have some underlying conditions. They did want to exclude the possibility of squamous cell carcinoma or other malignancy, and it was subsequently biopsied.
You can see here this kind of signs of frictional keratosis. There is, mucosal epithelium with epithelial hyperplasia, but clearly in the dermis there is this circumscribed stromal nodule, which is composed of these fascicles of neuroid spindle cells. So this is, you do not often see that, but the histology here is that of a traumatic neuroma occurring at this site, possibly related to trauma.
And just this patient did have a history of lupus, treated with azathioprine, so somewhat has a history of immunosuppression. It is definitely reasonable to biopsy this to exclude a malignancy. I don't know if there's any additional comments. This patient was reassured, nothing additional was done afterwards. There's some granulation tissue that's also present. So the diagnosis, this is case 14. This is a 48-year-old man, we go to the next slide, who presents with this generalized papillosquamous process. You can see that there's somewhat hypopigmented and faintly pink papules and patches with faint overlying scale. Some areas have a somewhat collarette or annular pattern here. Next slide. Some of the areas have large plaques with hypopigmentation and surrounding scale. So, this goes down the broad differential diagnosis clinically of papillosquamous, polycyclical, or annular lesions. I think it was biopsied, and you could think of, SCLE, you could think of leprosy, you could think of what we were talking about.
Well, and we saw the original biopsy on the right, and Dr. Nosby described that, but we got kind of one of these things like dermatitis unspecified, and that's kind of worthless pretty much. So when the EMR program puts that as a choice, you should never select it. So never ever put that down. And so after I started out as possible psoriasis rosea, which Dr. Nam will talk about that in a second. And then she sent me the clinical photograph is also extremely helpful to get. We love to get clinical pictures correlate with pathology. Ideally, at the time we see it the first time instead of after the fact. But once we saw this, well, that one thing for sure, it's definitely not pityriasis rosea. And then she took another biopsy, and Dippy's going to go through these.
So this was the original biopsy, which came without any significant clinical, information with it. And what you can see here, is pretty non-specific findings. Some mounds of keratosis, a touch of interface, but pretty overall. An unimpressive biopsy, some superficial perivascular inflammation, slight spongiosis. So, I completely agree with Dr. Cockrell. In that context, you would be like, okay, fine, this is compatible with pityriasis rosea, but does not make any sense clinically. And it was repeat biopsied, and the biopsy in this particular scenario, this is as classic as it can get. In my eyes, there is a superficial deep perivascular lymphocytic infiltrate, epidermal acanthosis, patchy lichenoid inflammation. And you can see a confluent broad keratosis, hyperkeratosis, spongiosis, prominent, lymphocytic exocytosis, lichenoid inflammation. There is vacuolar alteration, not a whole prominent disc keratosis, which is often not seen in this entity, but this intraepidermal lymphocytes are a clue, along with interstitial hemorrhage and perivascular inflammation. So this is very consistent with pityriasis lichenoides chronica.
So, Dr. Fernandez, you run a pretty complex clinic with a lot of referrals and consultations of rashes. And you get this all the time. It's kind of like, that doesn't fit. What's your approach, and how's your take on this?
Well, I think you pointed out that some of those lesions were annular on the arm, a little more inflamed as opposed to hypopigmented. So you can think about subcutaneous lupus erythematosus. So in an adult patient, for sure, asking them about what medications they're taking. There are certain medications that we worry about, SCLE, especially PPIs. Some serology, an ANA. Sometimes an ANA can be negative and you'll only have a positive SSA. But I think, rebiopsying, that second biopsy really, I think, the clinical pathologic correlation, as Dipti mentioned, fits extremely well with PLC. And I think you just go ahead and treat them as that.
Yeah, that's a good point. And I've seen patients, remember when I was a resident, Dick Scher had a patient, he followed a lady from Manhattan for about 2 years that had syphilis, and she was like in her late 50s. And it was called panniculitis-like, and clinically looked like it. He did have negative serology on this, and negative ANA and SSAs.
And also, I think, this diffuse, some clinical clues, if anesthesia over certain areas of the body, growth of, enlargement of the ears, clues like that can also be helpful.
Case 15, this case out in New Orleans. Basically, this patient is a 66-year-old man. He was admitted, I can't remember, for a drug-induced possible rash, if I remember correctly. And he had these lesions, which you could see on the left hand, or that would be the right hand, on the first digit, hemorrhagic papule, somewhat purpuric, and on the right hand, on the left side, you can see again another pink erythematous papule with somewhat, it might be a little pustule there, hemorrhagic blister on top of it. I don't know if there was another clinical photograph. Then they also presented with multiple other lesions that are hemorrhagic papules and plaques, some blisters and bulla, and then these were biopsies.
Are any of the presenters in this case and from New Orleans here? You want to make any comments about the case, or
Thank you.
we can go through pathology in the meantime if you want. Well, Dr. Anand.
Yeah, so, this is really something that dermatopathologist should be aware of, because I have seen them going down the wrong route on this. You can see here the biopsy shows an uninvolved epidermis. There is dermal edema. There is superficial deep perivascular interstitial infiltrate with a lot of blueness happening in the background. And when you go on high power, you can clearly see that there is a neutrophilic infiltrate with nuclear debris and dust. But in the background, you see all these haloed acellular structures. And if you were just sitting in your room without thinking really about the case, you would really go down the wrong path. These structures really look like fungal organisms, Streptococcus, with this kind of, the organism which contains mucin in its wall and produces these halos. And, that's what it looks like. You would do a PAS and a GMS stain, which was done in this case, which is completely negative for any fungal organisms. And then you have to always remember that any neutrophilic dermatosis with tons of neutrophils can produce this phenomenon, which has been described in the literature. And yes, and
So, we happen to have the individual. This was similarly presented a few
Look
years
at another biopsy too.
This looks like cryptococcus, but it really isn't. It's all neutrophilic debris. And another second biopsy done, which shows this kind of ballooning degeneration of the epidermis with spongiosis. Again, in the dermis, a neutrophilic infiltrate with, again, these cryptococcal-like haloed acellular structures, which again are neutrophilic remnants and not really organisms.
Several cases of this were published a few years ago by Dr. Fernandez. I don't know if you want to comment on.
Let's have the presenter maybe make a comment or
sorry
two
about
first
that.
to see what.
Hello. Yeah, it was a consult at our hospital here, and it was weird. She had these like polymorphous lesions. I think we had some more clinical images maybe, but there was like an area that looked like sweets on her elbow. And yeah, we just did the two biopsies, kind of given how different the two areas look like. And she had drug-induced SLE that we were thinking from hydralazine. She was still getting multiple contrast image studies for some reason. And so we actually called it iododerma. That kind of had this, this cryptococcal like histology. But there was areas clinically that looked like Sweet's-Lerner, which, apparently iododerma can mimic kind of those like hemorrhagic kind of pustules too that she had on her hands. So it was just it was weird, but cool histology.
There was a case that Omar Sangueza presented at one of our conferences a few years ago that showed the same phenomenon. So Dr. Anand is correct that you can see this. And this was a case of sweets that had the pseudo cryptococcal appearance, and that they interpreted this as positive for fungal organisms, and it wasn't. So it's something you just have to remember. And this Dr. Sangueza slide, and he very courteously left off Dr. Fernandez, who was one of the authors on the paper. So he's going to comment about the paper that he published.
Yeah, we were looking this paper up the other day. I think it was 2012, 2013. And I remember I wasn't the pathologist who read the slide, but I was covering our hospital consult patient on the very first of these three patients where we saw this phenomenon. And I think it's very important for both dermatologists and dermatopathologists to be aware of this phenomenon because it's usually sweet syndrome. And these patients are usually febrile. Your patient had drug-induced lupus. So on the clinical side, what you really want to do is give that patient steroids. And then you see this histologic picture that looks like cryptococcus, and it stops you in your tracks. And obviously you have to do the full workup and rule out cryptococcus. But knowing that that phenomenon can occur can be very helpful in allowing you eventually to have the confidence to start steroids, which is what these patients, of course, need.
So this is case 16. This is a 67-year-old female who was admitted to the hospital for shortness of breath and some weight loss. During her stay, she developed a rash that was somewhat generalized here. You could see here pink erythematous papules, some pseudo blistering that are somewhat hemorrhagic. The path was performed, the biopsy was performed.
So again, this is, one of the classic paths. You can see dermal edema, again, a mid-dermal dense inflammatory infiltrate, which again has neutrophils with debris. And now we already know that a dense neutrophilic infiltrate can induce these haloed acellular structures. There is, subepidermal vesiculation because of the dermal edema, which corresponds to the clinical villus appearance of this lesion. I believe a DIF was also done on this case, which was negative. And again, you can see what can lead you down the wrong path of this cryptococcal-like organisms, which aren't cryptococcus. So this is consistent with Willer-Sweet syndrome.
So after the 5 days of IV steroids, this patient had resolved essentially for all intents and purposes, which is what we would expect with Sweet syndrome. Case 17, this is, here you can see it there, this 69-year-old female with a history of breast cancer, but also had a 12-year history of a neutrophilic dermatitis, now with 1 month progressive rash and nausea associated, which happened to correspond with chronologically with the recent treatment with IVIG. You could see here on the clinical, there are large purpuric, both linear and oval shaped plaques with some slight scale. There's some areas of epidermal atrophy present as well as ulceration. These lesions were biopsied.
The presenters in this case in the room, this was the New Orleans case.
We also had this pseudo
Several clinical photos.
left hand with hemorrhage.
Here, she did ask me to look again at the path for this case because it was very challenging. So she had these like extensor lesion that we thought they looked like EED, mostly clinically. And then every time the path showed a lot of neutrophils, kind of consistent with more like a neutrophilic dermatoses. And then she did have another lesion that I was involved with her path, and she had a linear IgA dermatosis, which was a little different. I don't know. Do you have those clinical of her linear IgA?
Go to the next slide, Carlos. It's on that. I think it's right after that. There we go.
Yeah, so she did present after with more like these like beautiful pustules, like like bulla, and it looks a lot like linear IgA. It was positive on thank you. It was positive on DIF. It did have like the usual on H&E, but we were still trying to figure out what was this on the extensor. She had that for like many years. She has been on many immunosuppressive IVIG. I think she did rituximab for her for a short period of time. And she did a lot of other, she now put her on apremilast, and she is actually doing so much better, which just like randomly. So I would really love some input on these.
So I'm glad that you did say ED, because when we looked at this biopsy yesterday, that's exactly what it looked like.
Okay, good.
This was
Okay,
back from 2018, and you can again see kind of like a red zone uninvolved area of dermis. a little bit of neutrophilic infiltrate touching the epi here, but there is perivascular interstitial busyness, and you can see these prominent vessels, which clearly don't look healthy. So there is leukocytoclastic vasculitis, fibrinoid necrosis, destruction of vessel wall, mixed inflammatory infiltrate with dust, neutrophils, and eosinophils. So this is very much consistent with EED. This was, progressively over a period of time till 2021, the biopsy, this is what the biopsies kept on showing till her final biopsy. So this was again in June 2021, again, similar kind of, EED-like findings. You can again see the nuclear dust debris, the LCV, prominent endothelial swelling, consistent with that. But however, the most recent biopsy from August 2022, which classically, clinically shows blisters consistent with linear IgA, has a corresponding path, which is linear IgA.
Right.
Because you can see here this is for the residence, a subepidermal blister, which has reepithelialized, and this is pretty much diagnostic. If you get this slide in your boards, this could be two entities. It could be the dermatitis herpetiformis with these neutrophils at tips of dermal papillae, or linear IgA disease, and the DIF showed a beautiful linear deposition of IgA at the basement membrane, which would be diagnostic for linear IgA.
Right.
Yeah, we're thinking this is probably just a spectrum. She's got two
All
things.
these neutrophilic like stuff.
Yeah,
and
she's got,
it is very
and
interesting.
you can get EED associated with IgA gamopathies and things like that also.
Right.
And so we're thinking maybe they're both related in some way. So it's,
this
it's
is
a
this is
spectrum.
exactly what we're thinking. Yeah, we really like that y'all said that, because we always were getting like a sweet, and we were like, it looks like EED. And then when we reviewed it, it does have some fibrosis. It's just like it wasn't like all the way, and it has a lot of neutrophils. So maybe that was the confusion. So
Do you know if she's been evaluated for a monoclonal gammopathy?
yes, we did
Okay.
all the workup for perineoplastic. Yes, and everything is negative.
Whatever that linear IgA problem is probably tied into the EED somehow.
I
So-
agree. I agree on that. Thank you.
This is case 18. This is a 63-year-old female who has a base history of rheumatoid arthritis as well as lupus erythematosus. She's been treated with tocilizumab. You could see she presented with this kind of reticulated, somewhat red-brown, dusty plaques on the upper extremities as well as on the axillary area. These lesions were biopsied.
And again, this case illustrates a great example that, if you do not have the correct clinical history, you can just make a diagnosis on histology, which would not make a lot of sense clinically. What you can see here is a subtle busyness in the dermis, which you go on high power. There is a perivascular and interstitial lymphohistiocytic infiltrate present in between and among these swollen necrobiotic collagen bundles. And this looks very much like interstitial GA. There isn't mucin. There were some scattered plasma cells as well as mast cells within the lesion, but in conjunction with the clinical presentation and the patient being on that TNF inhibitor, it would be consistent with the broad category of reactive granulomatous dermatitis, under which you have interstitial granulomatous drug reaction. And that's exactly what this is.
Any additional comments?
We talked yesterday, you mentioned the fact that if you get GA, it's really a reaction to something. And then if you get it in an unusual setting, you need to think about this kind of thing, connective tissue disease, perineoplastic processes, those kind of things. So I think you just don't just slough off GA when it pops up in the middle of something, especially an older person.
I 100% agree. And, there are people in my practice who on every case of interstitial GA do want to mention the granulomatous variant of MF. And I'm always like, okay, I think we should leave it up to the clinician and, it would be, you will be dealing with MF otherwise on every case you've encountered. But I 100% agree with you that always should cross your mind. And it's important to get the correct clinical feedback, and you rely on your clinicians to make the right judgment in the setting. If something doesn't make sense, give us a phone call. We'll look at this because, we may be smarter than what you really think.
So this was signed as interstitial granulomatous dermatitis secondary to drug. Case 19 is a 67-year-old man who presents with a generalized rash. You can see here that the patient has some follicular accentuation with somewhat brownish papules, some areas scaly plaques. Here it's a little bit more pronounced on the lower extremities. Again, these reddish, scaly papules with some and plaques with some hyperpigmentation as well as follicular accentuation. On the feet, you see extensive plantar keratoderma with, again, a similar kind of well demarcated scaly plaques. Again, lower extremity on the lower leg, you can see a follicular accentuation. This was biopsied.
Again, this is a great teaching case for the residents. Beautiful clinical appearance and classic histology. You see psoriasiform epidermal hyperplasia, but disproportionate to the degree of acanthosis. You see this really bright pink stratum corneum, so marked hyperkeratosis. And when you go on high power, you can clearly see that the psoriasiform pattern, bulbous VD ridges, intact granular cell layer, and this nice alternating ortho, hyper, and parakeratosis, so-called the checkerboard pattern, with beautiful follicular plugging, massive follicular plugging, and parafollicular parakeratosis, classic findings for pityriasis rubra pilaris.
Any additional comments that would like to be added? How's the treatment for this, Dr. Fernandez? I'm sure you get a lot of,
Yeah,
very difficult to treat this.
Yeah, but I think it's getting easier in the age of biologics. Usually we start multi-drug therapies, acitretin, cyclosporin, try to get approval for a biologic, either a TNF inhibitor or an interleukin 17A inhibitor, most commonly. And over time, you know, I think the difference is between psoriasis is it takes longer for these medications to actually improve the eruption. But I think the biologics make a big difference, and we've been lucky enough to get patients under control. You know, we don't see this that often, but we see it often enough.
Thanks for that comment. Next case is case number 20. This is 61-year-old woman who presents with these pink, somewhat violaceous papules on the dorsum of the hand, which were biopsied.
And the biopsy again shows a lichenoid dermatitis. You can see this epidermal atrophy, hyperkeratosis, this lichenoid inflammation. When you go on high power, you can clearly appreciate the hypergranulosis. There is atrophy, but beautiful vacuolar alteration. You can see the cytoid bodies, marked pigment dropout, lymphocytic inflammatory infiltrate. Again, see the pigment incontinence, cytoid body, hydropic degeneration. So these are classic findings for lichen planus with pigment dropout, which, you know, I've been trained by Dr. Cockrell, who is a lumper rather than a splitter. So this would be a variant of lichen planus with pigment dropout consistent with lichen planus pigmentosis. Clinically, you know, there were other entities in the differential like erythematous chromicum persistens and systemic subcutaneous lupus, which the histology wouldn't really fit with. EDP typically tends to be more in the post-inflammatory stage when you biopsy, very patchy inflammation with subtle vacuolar alteration. The classic lichenoid presentation with pigment dropout would be consistent with lichen planus pigmentosis or just LP with pigment dropout.
Is the presenter here?
Who interestingly presented initially with facial hyperpigmentation as well as on her neck. This was unusual because her facial and neck hyperpigmentation had faded over the years. Actually, we'd successfully managed her over several years. And then she came in with this acute eruption on the dorsal hands. Interestingly, it looked very petechial to me. And when we biopsied it, came up with a lichenoid eruption, which I just thought this pattern was very interesting, and I'd never seen this on the dorsal hands.
Any idea of the trigger when you talked to her? And when she developed this, did anything on her face and neck become inflammatory again?
It didn't. And she had undergone, she'd been on years of hydroxychloroquine. She's been on multiple topicals. But I don't think she had any active treatment when this came up. So no, and we've also patch tested her in the past. I haven't followed up with her since these photos were taken, but we could consider patch testing her again because of the acral involvement.
Yeah, I think you'd want to rule out a lichenoid photodermatitis, maybe some medication she's taking or something like that
She's
too.
really not on many medications at all.
Or
Otherwise,
some
healthy female.
supplement, you know,
Right,
ward or
Right.
something like that. But no, sometimes the lichen planus just gives you funny morphologies. I've seen this before.
And at least unlike ashy derm where you feel when you do the biopsy and you don't see much inflammation, at least you're seeing inflammation. So the treatment will hopefully give her better results.
Right. And this is, we're catching it in such an acute stage. I'm hopeful.
So overall, I think these changes overall are most clinically pathologically lichen planus, possibly that pigmentation of the face could be associated, but that's what we were discussing yesterday. So next case, and by the way, thank you to the authors for adding information. It really adds to the discussion and helps us out with these cases tremendously. This case 20, Texas. This was a 61-year-old woman with several year history of these hyperpigmented round plaques. And then if you go to the next picture, there was a blister and occasional blisters. This one's just a picture of one of them. There was both it was a tense blister. There were both H&E and direct immunofluorescence performed.
The histology shows this lichenoid inflammation with bacular alteration and this subepidermal vesiculation, which when you look at it just like this, it looks like a Max Joseph's face, secondary subepidermal vesiculation from, a lichenoid infiltrate. But when you pay close attention to it histologically, and Dr. Cockle pointed that out yesterday, you can actually see this kind of a pattern of what you would see in a subepidermal vesicular dermatitis with these kind of, dermal papillae, protruding into the blister cavity. That certainly is peculiar, but you can also see the marked pigment dropout corresponding to the clinical appearance of the lesion. And exactly a DIF was done, which was very interesting because it shows beautiful linear deposition of IgG and C3 along the DE junction, which is consistent with bullous pemphigoids. And that kind of a pattern clinically with histology and the DI findings would be of lichen planus pemphigoides.
So this was my case. I actually was thinking about this yesterday. We were talking. Initially, I did think it was, you could go back. I just want to show the diff real quick. Just the diff. I think when I originally saw this, I was like, this is blistering. I was kind of thinking how I came to this diagnosis. And I remember I was thinking that it is, like you had mentioned, how do I know it's not just blistering LP or bullous LP? And I think that's how I was approaching it. But when I got the direct immunofluorescence, and I just want to, you could see that this actually has there's a split here. You can see the epidermis up here and the dermis out here. Lichen planus is not going to respect the roof or the base of the blister. It doesn't matter. It's just going to have deposition. This one actually has, you could see here on the roof of the blister, the linear deposition of IgG, or I don't remember if this was site C3 or IgG, this image, but it was one of the two. And that's kind of like where we kind of started with, okay, it's a lichen planus-like presentation, but has bullous pemphigoid features going with the diagnosis of lichen planus pemphigoides. I did go back, couldn't find if an ELISA was done, so I can't add. That would help if you are confused between the two entities. Although ELISA can be negative, diffs tend to be a little bit more sensitive, but ELISA is a little bit more specific. So I didn't have that information to add, but I'm on this one with this.
You treat the patient more like LP or like pemphigoid?
They treated the patient with topical clobetasol. They didn't do any systemic therapy. Patient didn't really want to do anything systemic. Also kind of in a remote location, very difficult for follow-up. So this kind of, she had no oral lesions or anything to be concerned about, or pharyngeal lesion to be worried about mucosal involvement. So they were comfortable with just giving her topical clobetasol, which basically didn't really do anything for the brown patches, but she didn't develop as many blisters. If she did, she could tackle it right away. Next case is case 22 out of New Orleans. This is an 81-year-old man with a rash predominantly on the chest for the last 3 months. You could see these pink erythematous papules on the upper and mid chest that are coalescing into a plaque, some erosions. There was pathology done on this.
So the pathology in here is kind of subtle. You can see this intraepidermal blister, which is, why is it blistering? Because there is acantholysis, so intraepidermal acantholysis, maybe some disc keratosis. So again, the panel yesterday was kind of conflicted. The people who presented this case thought that this was late onset Darius disease, we had the debate whether this just could be Grover's disease because of the very subtle histology.
Yeah, do you guys make the diagnosis of Darius disease in 81-year-old people that's been present for 3 months very common? It just really seemed to us like it was almost just a florid variant of Grover's. I don't know if the presenters are here, but I wouldn't get up and claim the diagnosis either. So
Now, you can have focal Darius in the pathology, and although the clinical pathologic correlation here, again, we talked about how important it is to have images several years back, like a team of experts. I don't know if you were involved in that paper, published paper out of the ASD in the Journal of Cutaneous Pathology, where they showed the correct diagnosis was increased by somewhat 80% with when having for inflammatory conditions, when having the clinical photographs. So we're just sitting sometimes behind a microscope and we don't have a lot of information and we're just like going at the fly. And there is a segmental Darius that can present somewhat similar to this with focal changes rather than more diffuse, just to kind of bring that up. But again, this clinical with path fits more with Grover's. Case 23. Sorry, move my paper along here. This is a 63-year-old man with a long history of these somewhat pink-like conified excoriated papules and plaques that is somewhat generalized. He had multiple different treatments over the years, including systemic steroids, pretty much failed everything. A biopsy was performed.
And, this is a biopsy that I would say we encounter like among the inflammatory derms 90% of the time. So kind of non-specific histology findings. There is epidermal acanthosis, hyperkeratosis. You can clearly see it's a spongiotic process. There is pallor in the epidermis. There is evidence of lichenification. You can see these kind of vertically oriented, stretched out fibers, and the infiltrate is a lymphohistiocytic with scattered eosinophils. So this would get signed out as a subacute or a chronic spongiotic dermatitis with eosinophils with a differential, that this pattern would either be that of a primary eczematous atopic or allergic contact, which it actually does look most like that. You could possibly raise the possibility of a drug reaction, though the infiltrate doesn't really go deeper to suggest that. And also a photoexacerbated dermatosis like photodrug or photoallergic dermatitis would give that pattern.
Dr. Fernandez, you get a lot of, again, complex inflammatory.
this case is from here too. Are any of the presenters in the audience by chance? This is a tough case, and it's like Gipti said, we see this every single day, and we really need clinical correlation to guide you in this.
Yeah, is there an approach you take? Because I know you get this a lot.
Well, I mean, obviously, you just look at it clinically. I mean, this looks like it would be a miserable rash to have. It's clearly been going on for quite a while. And I think the photo distribution that is described can be helpful in at least helping drive a clinical workup. Photo patch testing, asking the patient about medications, other triggers. That's what we do at the end of the day to try to get an answer.
The one thing I mentioned yesterday too is occasionally you get this in pimphoid. I doubt that that's what's going on here, but it's the right age group, it's so-called pimphoid nodularis. So maybe just for completeness purpose, I'm not going to rule that out. I doubt seriously that's what's going on here.
Yeah, I think there is an IgA linear IgA prurigo-like entity that presents like conified papules and plaques just like this. They don't have many blisters. And they're IgA linear positive with direct immunofluorescence. That's one thing. The second thing is, again, this patient might be a good candidate for Dupixent. So the biopsy is important to exclude the possibility of CTCL. So sometimes it's not just necessarily the biopsy will give us an answer per se, but it will exclude entities in which will allow us to pursue appropriate therapy. Case 24 is a 9-year-old girl who has underlying history of acute myeloid leukemia, who was treated with cytarabine and daunorubicin for a few days and developed this eruption on day 11. And you could see here their generalized pink erythematous, somewhat urticarial plaques. Some of them are annular. These lesions were biopsied.
And the biopsy shows this periacrine aggregates of mixed inflammatory cells. They're eosinophils, but also neutrophils. You can see some of them infiltrating the epithelium. So, this patient is on cytarabine and daunorubicin. So this would be consistent with neutrophilic equine hidradenitis, which is a known complication of those two chemotherapeutic drugs.
Case 25. This 12-year-old female with what has been stated here, 2-month history of these rash on the back, or lesions on the back. You can see a somewhat atrophic, areas of hyperpigmented as well as hypopigmented plaques. These lesions were biopsied.
Well, if it's at 2 months, it tells you how invaluable dermatology history is. Because this has been present for a long time. But patients sometimes come in with a giant tumor. It came up yesterday, or whatever. It doesn't itch, and they're sitting there scratching right in front of you. So morphology is more important than history in dermatology a lot of times.
I'm glad you call it.
And the histology kind of shows here an invisible dermatosis, minimal epidermal involvement. There is some dermal thickening, but also some attenuated dermal collagen fibers. With this kind of a clinical presentation, I think further evaluation of the dermal elastin and collagen concept would be useful. And a VVG elastin stain with some mild inflammation, not much happening. But the VVG elastin stain here shows definitely diminished number of elastin fibers with some disruption of the elastin structure. So this would be like kind of consistent with what has been described as atrophoderma of Pacini and Perini, which to me, it's like a late stage of morphia.
Yeah, and this would be a good example that if you got one of these dermatitis unspecified things, you wouldn't make the diagnosis. So you really have to have some good clinical correlation here. It's just very subtle. It almost looks like nothing on the biopsy. I mean, I think maybe one clue, it did have kind of a slightly squared appearance. So there's still probably a little bit of residual thickening, and also the eccrine sweat units look like they're in the mid-reticular dermal. So that's a clue that you've got more collagen than there should be. So if you got it earlier, it probably shows some frank sclerosis.
This is case 26. This 71-year-old man who presented with this. It was somewhat general, mostly on the trunk. You could see here some pink erythematous large plaques. Some areas you'll see polycyclical and even annular morphology. And then you see the cigarette paper type thinning that is a form of atrophy. This was biopsied.
And this was Carlos's case. I'm going to go ahead. Why didn't you describe the histology?
No,
he described it beautifully here
Nice.
again. And invisible dermatosis, very nice attenuated dermal collagen. And you can see here there is some perivascular inflammation with some histiocytes. And again, VVG elastin stain was done, which is diagnostic. It shows complete loss of elastin in the mid-dermis. And as Carlos pointed out yesterday, there's a beautiful histiocyte, which has this trying to like gobble up this destroyed elastin fiber. So these findings are consistent with mid-dermal elastolysis.
I think the nice thing about this case, previous one, is it shows 2 different clinical manifestations and histologic manifestations of atrophy. So the first one was more subtle, more of a deep atrophic process, probably due to loss of the fat and the collagen. Here you've got loss of the elastic fibers, and this gives you the cigarette paper wrinkling. The other one gives you the more, atrophic gullies that you see.
I've seen this a lot. I don't know why, but it happens across. And when I see like GA look clinical thing with atrophy changes, I kind of go to this diagnosis. But we're not, this would be signed out not infrequently as interstitial GA. I think a lot of you would agree with that to some extent. But anyway.
Well, I mentioned yesterday in the session that we presented a case. We may have actually presented here years ago, but we actually wrote it up. It's probably been 25 years ago now. But it was a lady that had acute onset acquired cutis laxa that was due to circulating. She had monoclonal gammopathy, and she opsonized her elastic fibers with the IgM gammopathy she had. The histiocytes came in and ate her elastic fibers also, and she got widespread horrible. She had the bloodhound faces and all that kind of stuff from that. So if you see this, you do want to make sure you're not missing an underlying gammopathy. I think this was worked up here and there wasn't anything.
Yeah, I don't think it was. She was worked up. he was worked up and there was nothing found. There's nothing that led to this. You did mention something about the diff on that patient.
Yeah, the DIF actually, they did it also. It actually showed IgM on the elastic fibers that the histiocytes were coming in and ingesting and opsonized. It's kind of interesting.
Okay, next case, case 27. This is a 66-year-old man with a known history of small bowel resection, presents with a history, presents with this rash, which basically have somewhat superficial erosions with crust, with a background of erythema and scale. This was biopsied.
And again, this is a very interesting histology. You see a psoriasiform pattern with bulbous VD ridges, dilated vessels, and you really think about psoriasis on low power. But then when you start paying attention, you actually see a retained granular cell layer. There's some slight pallor of the epidermis, keratosis, and not very well demonstrated over here, but there were some scattered necrotic radenocytes. So this kind of a psoriasiform pattern, not like psoriasis, no moonrose mycorrhizal abscesses, some pallor, keratosis, dead cells in the epidermis, should always raise the concern for a psoriasiform necrolytic process. And when that potential arises, you think about entities like necrolytic migratory erythema with glucogenoma syndrome, necrolytic acral erythema with hep C infection, acrodermatitis imperfecta with zinc deficiency, pellagra, as well as Hartnupp's disease, and the most commonly described association with deficiency of branch-chain amino acids, which is isoleucine. So this kind of, especially with this patient having small bowel resection, the possibility of an underlying essential amino acid deficiency was raised. The patient was started on treatment, which contained an aggressive regime of supplemental therapy. His hep C was normal, zinc was normal, kind of like on the lower limits of normal, but was put on a branch-chain amino acid isoleucine and responded like
This is the
well.
response. This is not before, this is after.
I think there's another picture after the second one. Yeah. And, please punch. we prepped a punch by. We're talking about this yesterday. Some of those look very, almost, they're purpuric and purplish. And, the patient might even have underlying atrophy blanche here as well. It could be treated. So it'd just be nice to see what's going on a little deeper than just basically barely beneath the epidermis.
Yeah, I didn't clinically think of it. Could be a vasculopathic kind of change as well.
There's that white material at her, down there on her lateral malleolus there. So she may have two things going on that's being missed, and that's something that's very treatable.
This case is case 28, and this is a 52-year-old woman with complex past medical history, head of medical history, who was actually consulted for this rash on the back. Seems a little bit more generalized and more on this back, but what you can see predominantly is almost erythroderma, dusky red plaque with areas of denuded skin, right? You can see there's some Nikolsky changes, not probably induced by the physician, but rather just from moving the patient around. So clinically, looking at this thing we talked about yesterday, this in a hospital setting, fits more of what would fit like the TN spectrum. Even ones that have edema and their TN without spots are somewhat concerning. There was a biopsy done.
And again, this is for the derm residents. Again, this is beautiful histology for TEN. You see a reepithelialized blister, this confluent epidermal necrosis right beneath the stratum corneum. This is the classic histology of TEN, which is drug-induced in this case.
So that's a great comment. Tony and I trained at a place with a lot of TN, managed a lot of TN, and you pretty much want oral mucosal involvement. Sometimes, though, it doesn't necessarily, because it's an epithelial disease, so it doesn't necessarily have to be visible oral involvement. Sometimes they'll just have like a sand type feeling in the eyes. Sometimes they have itchy throat, and that sometimes cannot be communicated, which in that context suggests that there's other epithelial involvement, and that's why. But yes, you're 100% correct. most cases, 99.9%, do have oral involvement or even perianal involvement, and that should raise suspicion for another entity. One entity could be an immunobullous disorder. There's forms of systemic lupus as well as other forms IgA that have been thought initially to be TN, and a good option in those contexts. That's why we always do direct immunofluorescence in patients with TN to rule that possibility out. I don't know if there's additional.
Well, there's a couple of things. First of all, depending on when you see the patient, it's going to look different. And I was the medical expert in a medical legal case a number of years ago where a guy went into the ER and he saw a doctor there, and it looked like a morbilliform eruption. He had a bloodshot eye, sore throat, didn't really look like TN or anything like that. So that he sent the patient home, and then a couple of days later, it looked like this. Ends up at the burn unit with chronic, with renal insufficiency and all this kind of stuff. And they sued the guy. And I said, well, it was diagnostic on day one. He even tried to get a derm consult. He was in a remote area. So early on, it doesn't always look like that. So you have to keep it back in your mind, because, if at day one it's been subtle, you may not be able to tell. Then 2 or 3 days later, then it can end up like this. It can really be a train wreck. Maybe
Yeah.
Tony comments on it.
Just out of curiosity, how long had this been going on by the time you saw this patient? Yeah. I mean, yeah, most likely at that point, you still would expect some mucosal involvement. But I think the fact that you have reepithelialization suggests that, this process is healing. It's not at its peak. So that could be another reason. But it's a good sign, too, that there's reepithelialization.
Well, the other thing that I think this was misinterpreted originally as possibly being like the other case that Dippy showed, that this was more of just ballooning degeneration from a deficiency disease. And it's not. This is actually a true, totally necrotic epidermis that's sloughed and it's got material that's still in that blister space. And then this is reepithelialized epidermis that's got that pallor because it's new epithelium. So you have to make sure histologically you don't miss that and have that pitfall, especially in a case like this where it's make different prognosis.
There are some, and I'll last comment because it's 9:30, but there are some things that I always document to kind of like decipher whether it's a benign drug rash versus malignant. That's the number one consult we get in the hospital. And I think it's very simple. I just check, are these lesions painful or itchy? If it's painful, it tends to be something bad. If they have lymphadenopathy, it tends to be something bad. If they have mucosal involvement, tends to be something bad. If they have high fevers, tends to be something bad. And then obviously the blood work. So there are things you could check to kind of like help you guide, at least check it off, write it in your note, that these are the more common presentations early on of patients with a life-threatening or potentially life-threatening drug rash.
And also, as a dermatopathologist, once the blister is reepithelialized, it's very difficult to point out the right histology. And I think doing a DIF to correlate with it is very prudent.
Next case, number 29. This is a 1-year-old Hispanic female. She presented with a 3-month history of this annular edematous pink plaque on a unilateral presentation, just one leg. She had no known underlying medical issue.
And you see the histology correlates with the fact that there's really no scale. It's an acral skin, and you've got this pattern of inflammation in the dermis of these pale cells. So you say low magnification is probably histiocytic, and you can see it's got a palisaded pattern here, and there's mucin between and among the collagen bundles here. There's also a couple of eosinophils, and you sometimes see that with GA, interestingly enough, in early lesions of GA. But this is a palisaded granulomatous dermatitis, and if I saw this, my first diagnosis, second, probably third diagnosis would be granuloma annulare. You can see the central mucin here with the histiocytes surrounding it, classic palisaded pattern, the so-called hysterosmosis of the storage of the mucin in the center of the palisade, and a little bit of degenerated collagen. So the differential would include other palisaded granulomatous dermatitis, including possibly, the interstitial granulomatous dermatitis associated with connective tissue diseases and others, so-called Winkelmann granuloma. But I think in the context of this pattern, to me, this probably is granuloma annulare.
The clinical protocol indicated that the diagnosis was thought to be potentially a reactive granulomatous dermatitis. And so the patient was referred for a workup, rheumatologic workup, just to make sure there was no underlying disorders that could induce a granulomatous eruption. And so far that hasn't turned anything up. And so I think once that is negative, then settling on a diagnosis of deep GA is appropriate in this child. Okay, our next case, this is a 49-year-old Hispanic woman who presented with a pruritic eruption on the eyebrows. This started 1 month after receiving a microblading treatment. She's had this for 1 month, and it was about a 16-month history that prior where she had a cosmetic treatment, which was microblading to the eyebrows. So microblading is it's a cosmetic semi-permanent tattooing procedure where a razor blade that has kind of a serrated, like a micro-serrated surface is used to introduce pigment into the papillary dermis. And the pigments that they use are supposed to be non-permanent because they don't contain the metals that are used for permanent tattoos. And so it's billed as a non-permanent cosmetic tattoo. And she had this treatment done and then developed this erythematous eruption in the treated sites.
So this is also a granulomatous dermatitis, but it's probably palisaded. It's more sarcoidal here, and it's with higher magnification. So it's got multinucleated giant cells here, epithelioid granulomas. Don't have any mucin or anything like that, but we do have this brown exogenous material. And what this material is, these are vegetable-based dyes that are used in this sort of non-permanent tattoo. And, because they're, quote, organic, end quote, they're far more allergenic than the non-organic tattoo dyes that are used for most tattoos. Now, we do see sarcoidal granulomatous reactions and sometimes even spongiotic reactions to other types of tattoos. But this, I've seen a number of these cases now that elicit this sarcoidal granulomatous reaction here. And we had another case that this lady was one of about maybe 15 or 20 women who went to a cosmetic, quote, seminar, end quote, in Dallas, World Trade Center there a number of years ago. This lady also was from San Antonio, interestingly enough, and she went up there and got these same type of microblading tattoos. Notice her lips are involved, her eyebrows are involved. I think the next slide may show one other area or higher magnification on the clinical. And her eye, you can see her eyelashes area, the lower lid was involved here. And she showed the same histologic pattern, this sarcoidal pattern. And a lot of these women actually had underlying sarcoid, and this reaction either was sort of Kepnerized their sarcoid into these areas. In some patients, they actually had subclinical sarcoid that caused them to get mediastinal adenopathy and lacrimal gland swelling, and they got sort of acute symptoms secondary to the tattooing. You see, shows the same exact morphology histologically. So, kind of moral of this story. Beware of these vegetable dye tattoos. Sometimes they're not so non-permanent.
Yeah, and the histology, I mean, it's pretty striking how deep some of the granulomatous inflammatory infiltrates extend, deeper than where you think the pigment is deposited. And so I think your point that, certainly there are cases of patients who present with granulomatous reactions to tattoo ink that they have underlying sarcoidosis. So when you see something unusual like that, you may want to think about working up the patient for systemic sarcoid just to be safe.
It was noted in the write-up that they planned to treat with intralesional Kenalog, that they had tried some and there was a little bit of improvement, and the plan going forward was just try to manage intralesionally. So I think this is going to be a tough case for the patient, but hopefully the Kenalog will help.
Have you tried any of the biologics, Tony, for granulomatous disorders? Like we've tried TNF alpha inhibitors for some of these with some benefit, but
Usually we can get them under decent control with intralesional Kenalog. I think if I'm remembering this patient, that I can't remember if they said the dose they used, but okay. But I think, in a patient who had the eyebrows, the eyelids, certainly we would consider a TNF alpha inhibitor, hydroxychloroquine, methotrexate. I mean, I think this is a patient who probably would be on board with trying whatever you thought could help. And we'd be happy to do it in a patient like that.
Next patient, this is case number 31. This is a 4-week-old male who was born at 36 weeks emergently by C-section and was noted to have hypoxemic ischemic encephalopathy and a concomitant hypertrophic cardiomyopathy and pulmonary hypertension. So very sick patient at birth, and a therapeutic hypothermia protocol was initiated to try to minimize or avert the encephalopathy. Shortly after the hypothermia was induced, the patient was noted to develop a subcutaneous indurated nodule on the occipital scalp, which also showed up on imaging as well.
Yeah, I guess they're really worried about a neoplasm in that setting, a childhood malignancy, but it luckily wasn't that. You can see that it basically shows a lobular panniculitis. Notice there's relatively a little bit of inflammation, a little bit of histiocytes in here, but the key is with the higher magnification, there are actually some crystals of fat inside the lipocytes and some of these fat microcysts here. And this is pretty classic for subcutaneous fat necrosis in the newborn. Scleremia neonatorum, I personally think is probably just a variant of this. They both have sort of abnormal chemical compositions of their lipid. They have too much palmitic acid, which can actually precipitate like this did, and then it induces a secondary inflammatory reaction. So it's not really an inflammatory panniculitis. It's really more of a chemical abnormality that then leads to secondary inflammation like this. And probably the cooling and whatnot did it in this case. Usually we see this on the dorsal surface of the back, so this is kind of a slightly unusual area, but I think Dr. Arcadi pointed out he'd seen some cases that do involve this area sometimes as well.
Normally, we think of subcutaneous fat necrosis in more like a healthy infant, and sclerema in neonatorum in the sick preterm infants, but the cooling protocol is a predisposing risk factor. So that's one scenario where you can see subcutaneous fat necrosis in a otherwise kind of non-typical setting. So in actually a debilitated or sick infant. Okay, our next case from Dallas. This is another infant, a 5.5-month-old boy who presented with a 1.5-week history of blistering on the feet, bilaterally on the soles, a little bit on the hands, but mostly on the feet. There was no past medical history to speak of, but he had received immunizations a few weeks prior, and he developed tense blisters on the bilateral soles and surrounded by urticarial plaques.
Yeah, this is a beautiful case, and we don't see this very commonly. Fred Golly is a very good pediatric dermatologist trained at the University of North Carolina that's in our community, very good asset to our community. But you can see a nice subepidermal blister with a band-like infiltrative lymphocytes and eosinophils that you see in higher magnification here. If we saw this in an adult, we would strongly favor the diagnosis of bullous pemphigoid. In a kid, obviously, you think about everything except that, maybe a bullous insect bite reaction, whatever. But in this case, this was bullous pemphigoid, and it actually was positive for linear IgG and C3. And here you can see the nice eosinophils and the lymphocytic infiltrate and the spongiosis, which is classically seen in the urticarial stage. This is some reepithelialization. This is to the side of the subepidermal blister over here.
Yeah, this is a really nice case. I've seen maybe 2 or 3 pediatric bullous pemphigoid cases in the past 10 years. And I think this is a relatively common presentation, these large tense blisters specifically on acral surfaces. And especially when you have urticarial lesions along with it, you do need to think about the possibility of this diagnosis, even though it's rare. And the other thing is, luckily in infants like this, when they have bullous pemphigoid, it's usually short-lived compared to adults. And so topical treatments over a relatively short period of time is luckily usually all they need.
I think there's another clinical picture. There'll be a post-therapy, so it's 10 weeks later, it got better. The first clinical photograph, I think, is kind of of interest as well. I think if you saw this, another thing you'd probably put differential diagnosis, especially given some of these lesions, might be monkeypox that we see as well now. So there's a case recently of a newborn monkeypox. I just read the article. I think it's one of our journals that kind of looked a little bit like this, but histology clearly is not that.
Okay, next case, another child. This is a 5-year-old boy who had a 2-year history of this erythematous pruritic eruption involving the face and extremities. And so he had an annular presentation with erythematous plaques on the upper arms, Also some on the face, and on the face they were leaving hyper and hypopigmentation. He developed some more annular lesions, a little bit less scaly on the lower extremities as well, some more inflamed and some more just showing dyschromia.
And this was a challenging case, and they've worked this kid up up the wazoo, basically looking for possible lupus erythematosus. I think it was the kind of thing they really thought it might be. And the histology is, theoretically could be similar. When you see an infiltrate like this in a child with lupus erythematosus, it often doesn't get the thinning of the epidermis, vacuole alteration, thickening of the basal membrane zone that you see with chronic discoid LE. It can look sort of like this. So we still sort of were wondering if that was the case. However, the workup has been negative. You see the mostly lymphocytic infiltrate here. He had another biopsy that actually showed a little deeper involvement involving some of the structures, the annexal structures, and had a little bit of perieccrine involvement here. So we said, well, if it's not lupus, well, then maybe it's a funny form of blaschitis. But I think we're still concerned that he might have childhood LE. And we've seen cases of childhood LE that can elude the diagnosis for many, many months, sometimes even years, before they finally declares itself. So I don't think he's out of the wood for lupus here. Totally, but at least for now, we're saying maybe it's a weird blaschitis until we prove otherwise.
He did have a serological workup and had no autoantibodies, ANA negative, and a rheumatology workup was recommended just for kind of a review of systems and examination, and that's pending. So I think there is a concern that this could manifest more definitively over time, so there's long-term follow-up needed. Okay, our next case. This is a 31-year-old woman with a history of systemic lupus erythematosus. She does have alopecia and presents with these hypopigmented atrophic plaques in the scalp. There were also some hyperpigmented plaques on the cheek. It was noted during the clinical exam that she had retained follicular ostia, and that was taken as a sign clinically that this was a non-scarring alopecia. She had a high profile, high titer anti-nuclear antibody and anti-RNP as well.
Yeah, this is an alopecia that I think a lot of people really don't realize or understand. And you can sometimes see this in dermatomyositis also, where you get an alopecia areata-like alopecia that's not AA. It's basically sort of an inflammatory alopecia. It histologically kind of looked like AA. You get polyps that are shifted into telogen. You might even see an occasional captain follicle. There's a lymphocytic infiltrate that's often around these structures, and it kind of looks similar to AA. But there's also mucin here, and you still see some inflammation of lymphocytes here around these follicles here. So this is the alopecia areata-like acute form of alopecia that you see with patients that have systemic lupus erythematosus on occasion. I think the next picture clinically shows that it was responding to treatment.
Yeah, so she was treated topically with clobetasol and showed new hair growth. And this is a one manifestation of alopecia. We normally think of discoid lupus or more chronic scarring plaques, but you can have non-scarring inflammatory alopecia in patients with SLE. And the retention of the follicular ostia on clinical exam is a clue. And then also, I think the path will show your retained sebaceous lobules, which is what we saw in this case as well. So both of those could be taken as signs of non-scarring alopecia.
There's some mucin here too that is a clue to the diagnosis. So we don't get this biopsy very frequently. I mean, it's fairly uncommon, and we don't really get too many biopsies. I think it's really a great case.
Our next case, this is another patient with lupus. This is a 38-year-old woman who had an established diagnosis of SLE and acute cutaneous lupus erythematosus. Her treatment was hydroxychloroquine. She had a history of other autoimmune diseases, including vitiligo and Sjogren's disease and rheumatoid arthritis. She had a clinical presentation with an eruption on the trunk that was described as polymorphous papules, some of which had a targetoid appearance. The lesions on her face were more annular scaly plaques. So she had two different morphologies, face showing us more annular scaly plaques, and then a more abrupt eruption on the back of targetoid polymorphous papules.
And the histology fit very nicely with what she's got. You can see if you just kind of look at the silhouette at low magnification, you see these perivascular traits of lymphocytes, which looks like one of the lymphatic infiltrates and would be something you would think about, for example, tumid lupus erythematosus or one of the variants of lupus erythematosus. There's also some mucin between the collagens you can make out at low power. Go to higher magnification, there's also got an interface dermatitis with dyskeratotic keratinocytes and a little bit of basket weed, fortified layer at the very top, a little bit of crust, which might correlate with some of those lesions. But this is sort of a combination of erythema performi and lupus erythematosus. And that fits with these targetoid morphologies, the acute morphology of the chronology of the process, and then the lymphocytic infiltrate. So this is Rowell's syndrome, which is kind of a combination of those two conditions.
This is a diagnosis that I've noticed, like in meetings and conferences and stuff. It's a little bit controversial about how you specifically designate this, and it's recognized as an overlap between lupus and EM. But I've always kind of heard people ask about, is it clinically more like EM or is the path more like EM? So how do you guys think of it? Is it more clinically going to look like EM or more like lupus? Where does that relationship? How does it play out?
The cases that I've seen, and it's pretty rare, have some clinical features that look EM-like, and then the histology's kind of got a hybrid of the two morphology. So this looks kind of like cases that I've seen over the years.
Yeah, I agree. I think definitely clinically you see targetoid lesions, and that's what makes you first think about Rowell's. And the histology, is a combination. I think you have a lot of dyskeratosis, but you clearly have other features of subacute cutaneous lupus. And I think that's the controversy. Is it really just severe subacute cutaneous lupus? Or is it truly its own entity? I think more recently, the last case I saw was a patient who it really seemed to be induced by omeprazole. And we looked up the literature, and there are numerous cases where that's been presented. So maybe that supports a little more that really what this is severe SCLE. It's something driving that. But I think you have to see the targetoid morphology of the lesions to even think about this diagnosis.
So our next case, number 36, from Fort Worth. This is a 52-year-old patient, a man with a remote history of possible sarcoidosis. He had this a remote history of a nodule excised from the forehead, which showed granulomatous inflammation and was interpreted as potentially representing sarcoid. And then more recently had developed an 8-month history of recurrent facial swelling, which affected the right side more than the left. And then the clinical presentation was a poorly demarcated, indurated subcutaneous mass on the right cheek, which had been fixed.
In the pathology, we don't have a low magnification that the presenter submitted, but it does show a involvement of the subcutaneous fat. Again, it's lobular panniculitis, so the septa really are not involved here. And it's got a higher magnification. You can see that it's filled with these atypical lymphoid cells here, hyperchromatic nuclei, very atypical. And note the rimming, the targeting almost really of these lipocytes here in these fat microcysts, which is classic for this condition, which is subcutaneous panniculitis-like T-cell lymphoma. This was the T-cell CD3 positivity. There's some CD4 cells, but the strongest binding was with CD8, which is classic for this condition. And there's two types of this process, the so-called alpha-beta type, which is a very low-grade condition that generally doesn't really cause any problems. And then there's the gamma-delta subtype, which can be extremely aggressive. So you really need to make sure you're not dealing with that form when you deal with this. The other thing that enters the differential diagnosis of this entity is lupus erythematosus profundus. And sort of that's what in the textbook, and if you ever call upon in grand rounds, you sort of throw that in the list. But generally, if you see this pattern here, you don't really need to think about tumid LE. So when I saw this case and the presenters that originally presented the case was a different group, I said I wouldn't put lupus erythematosus profundus in the differential diagnosis ever when you see this pattern like this, because you don't see that rimming around the lipocytes with lupus. This doesn't happen. You get diffused mummification of the fat. You get lymphoplasmacytic infiltrate that are nodules. They don't actually rim the lipocytes here. And I think there actually was an article, I think Dr. Mim actually published something a few years back about the fact that these lymphocytes, there's a selectin and an actual addressin where these cells are actually going straight to these lymphocytes here. So it's really almost pathognomonic for this condition when you see this. You don't have to think about lupus profundus.
So he was treated with prednisone and hydroxychloroquine and did show some improvement, but definitely concerning for lymphoma.
Yeah, and I'll say that treatment doesn't really go against subacute cutaneous T-cell lymphoma. I have a few patients that I follow and have treated with cyclosporin and prednisone, and they've both done extremely well. So despite the fact that this is a lymphoma, you do use immunomodulatory medications in many cases to treat it.
Yeah, the old CHOP regimen, prednisone is one of the P's. So absolutely.
Case. This is a 78-year-old man who had a 4-week history of an extremely painful purpuric eruption on the scalp. He had a necrotic and eschar presentation on the scalp, which he also reported a history of pain with chewing. There was a history of blindness in the right eye, but that was attributed to glaucoma. And the clinical presentation is essentially just a rapidly progressive plaque of necrotic skin covered by eschar.
And the presenter, Julia, just did a rotation with us. She's originally from Poland, and they immigrated to Canada, and she spent a month with us and actually wrote this case up. Angela Stiles, this patient from Clarksville, Arkansas. And see, the biopsy just shows a complete cutaneous infarct. Collagen is degenerated, eccrine sweat glands are necrotic, epidermis is necrotic. Again, we didn't see any active granulomatous vasculitis or any large blood vessels in this specimen, but this is diagnostic of ischemia that's probably occurring downstream from the blood vessel that was probably infarcted in the temporal artery, certainly a reasonable place where that could be ongoing. And you see here all these necrotic eccrine sweat glands here. So basically just kind of cutaneous infarct due to vasculitis is probably upstream from this.
Yeah, so the patient was diagnosed kind of clinically with temporal arteritis, although a temporal artery biopsy wasn't done, and treated with high doses of prednisone. Ultimately, this necrosis was excised and covered with a skin graft. Okay, our next case. This is a 67-year-old man who had a history of atopic dermatitis or presumed diagnosis of atopic dermatitis, being treated with abrocitinib. And then even on that treatment had progression of the primary lesions from a more scaly erythematous or eczematous patch to developing plaques, some of which had a lichenified or even cobblestone appearance.
We have two presentations in our sessions. One is the most educational case that we've decided on, and I think we may want to use this one for the most esoteric case because it's such an interesting presentation. When you look at these lesions, I mean, they almost look like the frog spawn of which you see with lymphangioma circumscriptum. They're just so markedly edematous. The biopsy, you can see there's some papillodermal edema here. The next biopsy shows it even more. It's got this band-like infiltrate of the cells here with prominent epidermotropism, low magnification. One of the first things we would throw in the differential diagnosis would be mycosis fungoides, and then higher magnification, you can see that it's loaded with these large protease collections here, these very atypical cells here. Now, the difficult diagnosis of this, and where we're sitting today and in Arkansas, would be HTLV1 lymphoma, which can look very similar to this histology. So I think that would probably need to be excluded. But here you can see the obvious atypical cell. So this is cutaneous T-cell lymphoma. And this is the papillodermal edema that's even more prominent. That correlates with what we're seeing here. I just don't see this clinically. It's just so unusual to see this in mycosis fungoides or really any T-cell lymphoma. So I think this is a fascinating case with just really good educational value to it.
I think also the clinic or the history of a prior diagnosis of eczema and then progression of disease on a eczema specific treatment is also classic for mycosis fungoides, although the JAK inhibitors, the new drugs, I think we'll be hearing more about these presentations, but I haven't seen that personally myself, but I don't know if that's something we think about that with people on Cellcept or Dupixent, and then disease progression, you got to think about mycosis fungoides. So probably true of any of the immunosuppressants. So this next case is a number 39. This is a 76-year-old man with a several-month history of purpuric to erythematous papules and plaques on the shoulders. So this was kind of a new onset, abrupt presentation, and clinically developed thin plaques or patches that resemble a bruise. And so it's mostly on the upper body, giving us a bruise-like appearance to the presentation. Initial workup showed a normal CBC except for low platelets.
And this is something that we as dermatologists really need to keep in the back of our mind, just like that desmoplastic melanoma we saw earlier, the amelanotic melanoma. When you see something that's kind of an atypical bruising in an older person, we obviously think solar purpura or maybe something that you're on a blood thinner or something like that. But you have to think about this diagnosis, because this is a potentially fatal diagnosis, 100% mortality rate if it's not treated, and it's misdiagnosed about 60 to 70% of the time initially. So we need to be thinking about this because the skin is a common site of presentation. You see, it shows this nodular infiltrate of these cells and even low magnification. So these aren't all lymphocytes. So there's a little bit of something's going on here because there's more cytoplasm, fairly dense infiltrate. It goes down into the subcutaneous fat and higher magnification. These are poorly differentiated blast-like cells. And they're atypical, there's hyperchromaticity, there's pleomorphism here. So this would be very concerning to us for some type of a malignancy. They don't look like classic lymphocytes, and these really are not lymphocytes. Here's another area down here that's positive. And to work this thing up, you have to do immunoperoxidase stains. This was positive for CD4, CD123, and this lesion is classically also positive CD56. Now, I've seen several of these cases that they almost always express CD123, but they have some spotty expression of CD56. But the way to remember this is sort of the mnemonic 1, 2, 3, 4, 5, 6, because it stains with those markers, and it's this entity, this plastic plasmacytodermal dendritic neoplasm. And there's new therapy for this now that actually can treat these lesions. They get 100% initial response when you use this new drug by Stemline. I can't pronounce the name of the drug, but it's one that actually works very well. So we really need to make this diagnosis, treat these patients early, because there's actually therapy now.
Yeah, I think your point about the bruising, that how non-specific that these presentations of blastic plasmacytoid dendritic cell neoplasm can be is important. And as you mentioned, Dr. Cockrell, this is something that dermatologists should be aware of, usually on the trunk. So they may look like bruises, but not in areas where you typically expect a lot of trauma in an older individual. Think about the possibility and just do a biopsy to know what you're dealing with.
Mark Bubrall said at the Fall Clinical last year that he actually made the diagnosis on a couple of patients after he kind of heard one of the presentations about it. So it is something, if you don't think about it, you won't make the diagnosis.
The key is to make the diagnosis as quickly as possible, because this is a very aggressive tumor, and the longer you delay the diagnosis from a clinician or from the fact point, you are progressing the course of the disease.
This is, I just always thought these tend to be CD31 positive, and I actually learned it from one of Dr. Fernandez's residents that he had trained. I never understood why, but it can be used as a surrogate marker for this entity on top of CD56. Not uncommonly, they're CD45 negative, but I just thought it was unusual immunoprofile because we use that typically, as you guys know, vascular marker.
Yes, to comment on that, I've seen a couple cases of this that are recognized to be like an atypical lymphoid infiltrate, but it's negative for CD3 and CD20, which is usually how we start a workup for something like that. And so this is a diagnosis that you might not really key in on if you don't use a really expanded panel of markers and get the 56 and the CD123. So that's one thing. The other thing I was going to add was that the presentation is usually first in the skin. So a lot of our patients with leukemia or lymphoma and skin involvement have a nodal or systemic disease that later develops skin involvement. For this disease, it usually presents first in the skin. So dermatologists are probably going to be the first people to make this diagnosis, and we can't expect that they would already have manifested blood involvement at the time of diagnosis. Okay, case number 40. The next one, this is a 77-year-old man with a history of non-melanoma skin cancer and prostate cancer who had an abrupt onset of tender erythematous nodules on the buttocks and also on the elbows and extensor surfaces of the extremities.
Any of the presenters here from this case? It's a New Orleans case. Maybe Pam, you want to comment?
This isn't my case. I was peripherally involved, and I really haven't even ever seen the slides, which I would love to see. But I think the teaching point here, this is Caroline Lee, who was a former resident who was awesome. And the 3 teaching points are: use all of your clues. This was an older man who came in regularly for BCCs, squamous, and he had an ill wife. Well, the first clue was that the wife was with this man for this appointment, which meant something's up. And she did the initial biopsy. It was read out as EAC, but it did not fit EAC clinically. And so the second lesson is be dogged about it. So she asked for pathology to review it, said it did not fit EAC. They stuck with it. But in the meantime, she's looking at this man and sees that he is really looking sicker and sicker. And so she got a CBC and he had like thousands of blasts. So he had AML. So she diagnosed AML, and actually he even started treatment before they finally revised the diagnosis to the correct diagnosis. So if it doesn't fit, be dogged. Just, we all want to tie a nice little tie and get the patient out, but I admire her persistence.
Well, I could see how they might think EAC or maybe even Pernio, when they look at this. But if you look carefully, and the next biopsy is really more characteristic, these aren't really sort of jet black as we talked about at low magnification. And you look at higher magnification, they look kind of similar to the cells in the lesion we just saw a second ago. They're not homogeneous. They vary in size and shape. And then if you look also inside these small capillaries up here, the same cells are present inside the lumen of these capillaries. So this is a systemic process that's really involving this patient's skin. And here, these are pleomorphic cells. I mean, this large cell here, they vary in size and shape. So this is not just a lymphocytic infiltrate. This is an atypical cellular infiltrate. They're not pure, they're not lymphocytes. They're probably more kind of like these blast cells that we saw in that last case. And this was the first case, which says leukemia cutis excluded, but I'm not so sure it totally really does exclude that these cells are in the hematologic category. So this is, I guess, lysozyme CD34 myeloperoxidase stain, but it did stain positive CD123, which is a marker for AML. And it's also a marker for the blastic plasmacytoid dendritic neoplasm that we just saw a minute ago. And so it didn't stain positively with CD56, but again, these things don't always read the textbook. These markers are seen in that entity as well. So I think it probably, and again, they say it's negative, but there's a few cells that are positive here. So I personally am not so sure, maybe it's not exactly this entity, but it's in the family of that entity, which is in the family of AML and the leukemias, the hematologic AML myelocytic lineage. So I think that it's really this entity that it was simulating a giant erythema histologically the first time, but that's the same process in that skin biopsy also.
This patient had a bone marrow biopsy showing AML, and due to the advanced stage, was started on palliative chemo. Okay, next case, number 41. This is a 68-year-old woman with erythroderma and pruritus who developed a several-month history of erythematous plaques on the back. So she had mostly kind of an eczematous or patch presentation, and then recently developed some plaques.
So see, at low magnification, it's got this band-like infiltrate of cells, lymphocytes, little psoriasis hyperplasia, not really much fungiosis. And then unfortunately, we just have a shave biopsy. It would have been nice to get a punch again to see what's going on down deep. You can see there is some perivascular inflammation with some interstitial inflammation also, which I think is important to the diagnosis here. So here at higher magnification, again, patchy band-like infiltrate, maybe a little tiny bit of few cells at the basal cell layer here focally, but certainly nothing like we saw in that case a few minutes ago where we actually had these prominent protease collections. This is another biopsy that was taken that now is much denser and diffuse infiltrate. And I know Dr. Pernichieri has already mentioned this a little bit earlier, but now we've got histiocytes in here in addition to atypical lymphocytes and some eosinophils. So these lymphocytes now are obviously atypical, reniform nucleus here, variability in size and shape. And if we look carefully, you might even see some of these lymphocytes inside the cytoplasm of some of these histiocytes in the background. So this was a patient that had the early patch stage lesion of MF and may have had some dermal involvement if we'd have seen a punch biopsy that was really very difficult to diagnose on the H&E. The second biopsy showed this granulomatous infiltrate with these atypical lymphocytes. We were able to make a diagnosis of granulomatous mycosis fungoides, and we did do T-cell gene arrangements here, which were positive.
Yeah, one thing you see in MF as it advances is that the cytokines turn more towards the Th2 phenotype, and that's when the eosinophils start to show up in the pruritus, especially. So EOs may kind of distract us, but they're actually something that you can see in the advanced mycosis fungoides.
And she's got some, again, atrophy here and maybe sort of heading towards the spectrum of granulomatous slack skin syndrome eventually. I don't know if she's ever going to totally end up there, but she's on that spectrum.
Pretty extensive involvement clinically. And histologically, I think granulomatous MF can be very challenging. You often don't see such a robust inflammatory infiltrate. So again, I think having clinical pictures like that could be very helpful when a pathologist is trying to determine what's going on.
Okay, number 42, the next case is a 47-year-old man. He had a history of hypertension. He was a smoker and had a new onset triad of dysphagia, odonophagia, and nasal obstruction, which had developed over the last 3 months. And then more recently developed some skin lesions, which were erythematous, indurated plaques and papules, mostly on the scalp and face. He was also noted to have cervical lymphadenopathy.
Here today. It's a New Orleans case also.
This is really a tough case. I saw this patient one time as an inpatient consult, and I was just following on him because he was like super interesting. So he got these like random, really, some of them look a little bit complicated, kind of papules. He had a little bit more on the mandible, a little bit like hiding in the beard. And he also had something in his mouth that we couldn't really see as much, but it was a huge ulcer. And everything was like acute. So we biopsied one of these lesions and we were looking, it didn't really has all the features that we were want to think of when we have these mucosal lesion of that like entity. And I think you're going to talk more about it. But it definitely, we were also thinking, is this infectious? Because also he did have like lung involvement. So we were going along that. It's more neoplastic, and we were kind of fighting that until we got the biopsy from the mouth, which was definitely much more helpful and lead us into the right direction. But I think that Stella cases can be very, very.
Well, yeah, the biopsy, again, low magnification, you see it doesn't have a lot of very dark staining cells. So these are going to be more sort of like histiocytoid-like cells. And you can see, again, they're very pleomorphic, a lot of cytoplasm here, marked variability in the size and shape. So this would certainly be very concerning for malignancy. And we would work this up too by doing additional markers on it. This was the lesion of the palate, which shows the same infiltrate here. And I believe this is some of the, maybe a little bit of the epithelium of the palate. It's kind of ulcerated there. And it shows that there's some T-cell differentiation with CD3 positivity, but CD56 was strongly positive. And I presume I'm sure you did other markers, and these were really
the EBER was positive.
That's the other thing that was really helpful here. Yeah, that EBER was positive. That's really very commonly seen in this nasal type NK T-cell lymphoma, and Epstein-Barr virus, very common. A lot of these are seen in Far East and Asia, but we see some of these in this part of the country also that are EVER positive.
And I have to mention, actually, Dr. Freeman is in the audience today, and we had a really interesting patient who had an MF-like presentation with progressing patches and plaques with no nasal involvement. And the histology of that case, which has been actually described in literature, can either look like MF or a dermal-based lymphoma, or can even mimic a lupus panniculitis. And for the longest time, it was thought that that patient probably had a lupus panniculitis, but had progressive disease worsening, and was finally eventually diagnosed to have extraneural natural killer T-cell lymphoma of the nasal type. So it's the most common presentation is with that destructive nasopharyngeal mass, but the second most common site of involvement is actually in the skin and in the GI tract. So it can definitely have an MF-like presentation with patches and plaques in a progressive, rapidly progressive course.
Right. And this is what I told my resident. I was like, they can be very atypical. And although we also talk about like angiodestructive, but sometimes they don't really have that feel on skin, and you can see it more in the mucosa. So that might be like a little hard to diagnose.
This is a pretty aggressive tumor also. How's the patient done? What kind of therapy?
I think they started him, he was referred to HEMONC, and they started him on therapy. I don't go to that hospital, so we only cover it on consult. So I don't really know what happened after.
Yeah, the write-up indicated that he was started on chemo and radiation. But generally speaking, I think the CD56 positive lymphoproliferative disorders tend to be, it's a differential that pretty much all of the diagnoses are pretty serious. So CD56 is one of those markers to keep in your panel, and when it's positive, most of the diagnoses are pretty serious.
But it's again a very simple diagnosis to make when you think about it, because it's one of the few T-cell lymphomas in the skin which are CD56 and then EVER positive with that kind of a presentation.
Yeah, I think the histology of the cells too kind of interesting. This just doesn't look like small lymphocytes. They look almost histiocytoid in a way. Now, kind of a little bit like the CD56 lesion we saw before with the DPDCN.
Okay, our next case is a 31-year-old man, otherwise healthy, who has a skin-limited presentation. He gives a history of intermittent eruption of red papules that are asymptomatic. This is the newest lesion, which is noted on the left arm, been present for about 2 weeks, although he has had other lesions present on the trunk, the thighs, and both the bilateral arms. And usually the lesions will become crusty and then they go away on their own.
And this, again, we didn't get all that history when we saw the original biopsy. This patient at the VA hospital, I believe he might have first been seen outside the VA, and then maybe he was seen in the VA secondarily. But this is the pattern, and you can see it's a psoriasiform lichenoid infiltrate, superficial and deep, with some clear staining or lighter staining cells here. So some of these are probably going to be histiocytes or histiocytoid. And you see that they're not all lymphocytes. So let's go to higher magnification. Many of them are some neutrophils, and they're also relatively abundant plasma cells, that you can see up in here. But there are also some atypical cells in the background. But we were really struck by the plasmacytoid morphology of these cells initially, and so we worked them up for the possibility of syphilis. And basically, that was all negative. And then we eventually saw that he was getting more lesions kind of coming and going. We did CD30 stain on it, positive. So it turned out to be lymphomatoid papulosis with plasma cells and plasmacytoid morphology of a number of the cell, which is relatively uncommon. And so that kind of threw us off base a little bit. And there's an article published just recently, last month, in the American Journal of Dermatology. It's a letter talking about CD30 positive cells and syphilis. So there's some overlap between these two. So this was an interesting take that originally kind of fooled us and turned out to be lymphomatoid papulosis simulating syphilis. This is the other situation, it's going to reverse, where you get syphilis that's got CD30 positive cells in it.
And he did have an RPR done, which was negative. So the clinical pathologic correlation led to the diagnosis of LYP. And in this case, he has been relatively free of any further eruptions. So he's just being monitored at this point, but no specific treatment at this time. The plasma cells, I'm not aware of it being something that's reported, but maybe
You can see some in there on occasion. It's just pretty uncommon, you know, and I mean, if you look it has so much inflammation there, you couldn't really see the atypical cells that much in the original biopsy. Second biopsy, they were more characteristic, I thought.
right.
Let's call it type P for Percuro, maybe.
Okay, next case is number 44. This is an 82-year-old man who had a history of a myeloproliferative disorder and a known JAK2 mutation, who developed a new eruption of coalescing erythematous papules and eroded plaques in intratriginous areas in the groin, and also in the postauricular sulci and on the shoulders.
And this, I think, is another lesson when you see kind of a diffuse or chronic erythematous eroded areas in the intertriginous sites that don't respond to usual therapy. Don't just keep putting more Lotrimin on there or whatever you're doing. Take a biopsy. And they did that here. It shows this band-like infiltrate. We don't know how deep it goes, but of these cells, again, that are pale at low magnification. As you go to higher magnification, you see many of them have a classic reniform nuclei. There's some plasma cells in there also, probably because of the location. But many of these are Langerhans cells, and these were stained positively with the markers for Langerhans cells. You've got some eosinophils in here, which you classically see with Langerhans cell disorders. Some of these cells have that reniform nucleus here. And then this is the CD1A, which is strongly positive. And you can also see the epidermatopus of the cells, which is classic for Langerhans cell histocytosis. So you have to think about this, and I've seen this several times over the years, and it's usually a delayed diagnosis because people don't think about it. They usually just think it's inverse psoriasis or intertrigo or fungal infection, and if it does respond to therapy, take a biopsy. It could be this, extraordinary patch disease, could be a number of things.
So we were discussing, and it was noted in the protocol that most of the time, Langerhans cell histiocytosis has BRAF mutations, but there are some cases where JAK2 mutations are the drivers for the LCH. And so probably the case in this patient who had a concomitant myeloproliferative disorder. And so his treatment was really focused on treating the myeloproliferative disorder. Our next case, number 45, is a 47-year-old woman who had a 6-month history of an asymptomatic eruption on the face, basically consisting of erythematous papules and patches on the nose and cheeks. The clinical diagnosis was rosacea, and she was treated with oral doxycycline, topical metronidazole cream, and did not have any improvement, so biopsy was performed.
Well, and you can see clinically, I think rosacea would be absolutely a reasonable thing to think about, at least initially. Obviously, once again, things don't respond to therapy, take a biopsy, and you can see it shows this very dense band-like infiltrate, nodular and diffuse, if you will, sparing. Got a nice Grint zone here, which we usually kind of calls to mind a B-cell proliferative disorder when we see that. So this is kind of unusual because T-cell conditions usually get epidermatopus, where they don't spare the papillodermis. But on higher magnification, these cells are very pleomorphic, hyperchromatic. Some of them are convoluted, so this would be more characteristic of a T-cell infiltrate just on morphology alone. But obviously, you'd work this up with additional stains. And so here we see the CD3 is strongly positive. CD4, however, is largely negative, just a few slightly staining cells here and there. CD5 to CD7 positive, and then CD8 was strongly positive. And I believe they worked this up with some genetic abnormality studies, and they didn't find any gene rearrangements. So this is basically what they're calling primary cutaneous acral CD8 positive T-cell disorder. And basically, we know about the CD4 small, medium-sized lymphocytic disorder. They're calling these things lymphoproliferative disorders rather than true lymphomas. And this is I haven't seen a CD8 one before this case. So this is kind of interesting that this highlighted primarily with CD8. Usually we tend to think of CD8 as being more aggressive, and the cytology of this looked more aggressive. So I guess so far she's doing well and hasn't really had any other abnormalities.
The plan and the protocol was to treat with intralesional Kenalog. So they're not going to treat too aggressively, at least for now. Next is number 46. This is a 61-year-old woman who had a history of multiple myeloma. She was status post stem cell transplant and on treatment with lenalidomide, and she had developed a new onset cutaneous eruption of papules and subcutaneous nodules involving the right ankle and also the left eyebrow and scalp.
Any of the presenters here for this case, by chance?
Referred to me by hemonc for this lesion, and actually, like the referral and clinically, we were thinking about plasmacytoma. It was like a classic presentation, and on path, it looks beautiful. I mean, she was sent back to treatment. She did have transplant initially, and they're gonna change. So this is considered progression of disease, unfortunately, and they have changed her treatment management now, and I think these have faded away with the new regimen.
Okay, thank you for that. Well, you can see the once again, you have a dermal-based infiltrate of these large cells, again with relatively abundant cytoplasm. I noticed the sparing of the epidermis and the pachydermis, rim zone. In higher magnification, you can see that these are plasma cells, all of them basically, and they are hyperchromatic. They vary in size and shape. They're atypical. I don't see any mitotic figures in this field, but I'm sure there probably were some in other fields. And this is CD138 just confirming that they're plasma cells. So this would fit nicely in with a plasmacytoma. The kappa light chain shows basically nothing, but you can see how strongly expressed the lambda light chain was, demonstrating a nice light chain restriction.
Next case, number 47. This is a 42-year-old multiparous woman with a 6-year history of a painful enlarging nodule on the umbilicus. She did have a history of dysmenorrhea and endometriosis and had undergone an endometrial ablation. It was also noted that this nodule was subject to cyclical swelling and episodic pain.
That's a classic example of cutaneous endometriosis, but when you get nodular lesions on the umbilicus, you have to think in terms possibly of metastatic neoplasm, the underlying GI tract or the GU tract. So I'm sure that's one of the reasons they did the biopsy. And this shows it's a very good biopsy. It was taken probably by an excision technique. And you can see the classic features of cutaneous endometriosis. These little glandular structures here are classic for endometrium. You've got the residual stroma here and the blood inside the area. So these things are actually undergoing the cyclical process, just like her uterus would undergo. And these often do have variability in pain and whatnot with the menses. So it's a nice example of cutaneous endometriosis.
And the treatment here was just an excision of this nodule. Our next case, number 48. This is a 47-year-old man who did have a history of basal cell carcinoma and developed a new rapidly growing nodule on the chest present for 10 weeks.
Is this your case too? No? We had a little disagreement with the diagnosis here, but tell us what you think here.
Patient was a young male, no previous dermatologic history. He had mashed on this lesion for a few days prior, which it was unusual because it looked bruised. You can see that it's kind of yellowish around there and very firm and adherent. So there were a lot of aspects that made this concerning for a biopsy today rather than putting this off for a full excision.
That's a very good comment made by obviously an extremely good dermatologist who's been well trained. And she took a good biopsy also, very large, probably just like an enucleation biopsy, kind of just try to shell the whole thing out. Yeah, good. Very, very good. We love these kind of biopsies, so thank you. And it shows features of palmicrocoma. As you can see here, these are the shadow cells. These are the basaloid germinative cells of the lower part of the hair follicle. And this is a classic area of palmicrocoma right here. I mean, this is board 101. You guys better know this. But there's another area here that is not typical of palmicrocoma. You can often see mitotic figures of palmicrocoma because we all know the germinative epithelium of the hair follicle, second fastest growing part of your body after your bone marrow. But you don't get these kind of cells in a pilomatricoma. These are very atypical, bizarre mitotic figure. These cells in the background are quite atypical. Look at these prominent nucleoli, multiple nucleoli, very aneuploid looking cell. So what happened here is that he's got a plastic pilomatricoma that is focally degenerated into malignancy in an area. They call this proliferating pilomatricoma, but this is more than just proliferation. This is frank cancer. And a lot of times these adnexal neoplasms, this is adnexal carcinomas. This is how they develop. You have a pre-existing benign lesion, like a hidradenoma that sits there for many, many years. And then suddenly, well, not suddenly, just over years, it'll gradually degenerate into malignancy. And I think that's kind of what happened in this guy. So it definitely needs to be fully excised. I'm sure you've probably already done that. He'll probably live happily ever after. But this is not just purely benign proliferation here.
Dr. Cockrell, just out of curiosity, I think at the Cleveland Clinic, we would probably look at this case in consensus with our group. And my gut feeling is we would probably sign this out as proliferating pilomatricoma with focal degenerative change. Describe it. Would you call it a malignant pilomatricoma, or how would you sign this?
I think it's probably pilomatric carcinoma X, sort of analogous to where the oral pathologists sign out pleomorphic. They call it pleomorphic adenoma. They call it pleomorphic carcinoma X pleomorphic adenoma. I think this is analogous. I wouldn't just leave this alone. I would say that it's undergone focal malignant degeneration and say that it's also got the benign component, but this one area has turned into cancer. Just make sure it's out.
Yeah, I think seeing this would definitely make us recommend re-excision and make sure you have negative margin.
The reverse of this is where we see proliferating triclinal tumor. They get called squamous cell, and that's benign. And we see that probably once every couple of weeks.
Okay, next case, number 49. This is a 58-year-old man from West Texas with a history of liver cirrhosis who developed this dusky red scaly plaque on the right ear for 1 month. There was cervical lymphadenopathy noted on this side as well.
Dr. Patty's going to make some comments about this one too in a minute, but this is we talked about the ioderma case before. And when we talked about that in the conference yesterday, we sort of said, well, maybe that's just a weird sweets, because usually when you biopsy iododerma, it looked like this. You see this marked lupus pseudocarcinoma thermal hyperplasia here with all the neutrophils and infiltrate. This one's also got histiocytes, so this is a suppurative granulomatous process. And so residents, when you get on the board examination, if you see this slide, you want to instantly start going on a bug hunt. You want to look for organisms in here. The best place to look up in this area because you get transepidermal elimination of the organisms. And actually, some of these clear areas right here might even be hyphal elements possibly from this thing. You also want to look in these abscesses and then look inside the histiocytes. So those are the places to look when you're looking for organisms. So we have this photograph here. We don't see any organism just yet, except right here. There's one inside that histiocyte. So there's one there. I don't really see any in the abscesses here, but in this area, Dr. Cotty's got us a nice high-power view of a spherule. So this is coccidioidomycosis. And the thing that in the differential diagnosis of this is rhinospridiosis. That also gives you spherules, but that's much larger. And they're actually actually sort of in almost a different, it's not really a fungus. It's almost like a parasite. So it looks different than this. Dr. Cotty, you want to comment?
So yeah, I was actually down the rhino, and then I was like, oh man, maybe it's something, cocci, and eventually figured out after a day of back and forth. But two things. One, like you mentioned yesterday, a lot of these pseudoepitheliomatous hyperplasias, they're diagnosed as squames, and you end up getting your ear cut off, but it's an infectious process. So if they're microabscess formation and granulomas, you got to make sure it's not infectious. The second thing is this guy did have imaging of the chest. He had no pulmonary involvement. So, and he did not have any other lymphadenopathy. However, he had ipsilateral lymphadenopathy. We actually favored that this is primary cutaneous, which is extremely rare. We can't prove it yet because maybe it's smoldering. Later on, he will develop systemic theoretically, but we could not find underlying pulmonary and other node involvement just in that area. But he was lost follow-up. I don't know what happened to him. They did everything when he was there in the hospital, and then
Did he get treatment and went away? I mean, this thing can kill you if it's not,
He did get fluconazole treatment. Our next case is a 69-year-old woman who had erythematous plaques in the inguinal, inframammary, and axilla, so intratriginous distribution. She had been treated with topical nystatin triamcinolone cream and noted no improvement, and also had a KOH done in clinic, which was negative.
another one of these intertriginous eruptions. And again, if they don't respond to treatment, take a biopsy. And they did that here. It's a nice little punch biopsy. And you can see it's got this thick hyperkeratotic area up here, cornified layer, minimal inflammation. And as we go to higher magnification, kind of hard to see on the scan, but this basophilic material here, there actually were filamentous bacteria that were up here in the cornified layer. Kind of hard to see, but they actually, you could see them with routine H&E. So this was an example of erythrasma that was involving the intertriginous areas here. And I
this
believe she
patient was
eventually was
treated-
put on proper treatment and it went away.
Yeah, she was treated with clindamycin solution and improved.
Just one other sort of thing I'll mention. This doctor, Dr. Gary Cox, who practiced down in Victoria, Texas, which is South Texas down there, and again, sort of a semi-rural area, a very, very good clinical dermatologist. He actually allows us the ability to go into his EMR program and view his actual clinical photos, which is super helpful. And I'm sitting here with the microscope, tough case. He's not sure what it is. I can look at the picture, say, well, that's consistent with erythrasma. We do the stain on it or whatever, improve the diagnosis. So for those of you in practice that have EMR programs, I work with your dermatopathologist to allow us to have the access to that because it really improves, just like the CPC we're doing today, getting better diagnoses for your patients.
At the Cleveland Clinic, we've implemented sort of a, an unwritten rule that clinicians take photographs of everything they biopsy, whether it's an inflammatory condition or a potential neoplastic phenomenon. And just to reiterate what you're saying, I mean, having clinical photographs when you're trying to interpret histology is invaluable.
I would say that it's probably become standard of care.
There's going to be a lawsuit at some point, and the burden of your liability in this thing is it's the old thing that's called the learned hand formula. If the burden to do something is lower than the potential risk of not doing it, well, then you're considered liable if you don't do it. And given how easy it is to take a picture today, stick them in an EMR or shoot it over the internet to us. There's going to be a suit someday where a misdiagnosis there is going, well, did you take a picture? Well, no, I didn't. Well, why? It's so easy to do. And if you'd have sent the picture to the pathology, wouldn't they have gotten the right diagnosis? Yes. So, and the place I would say, if I could say one place you always need a clinical photograph are nail unit pigmented lesions. Period. End. I don't think you should even look at those things unless you have a clinical photo. I've seen so many cases where it almost looks like nothing under the microscope, even with special stains. And then you see the clinical photo and it's like obviously melanoma. And same thing with acral lentiginous melanoma. Sometimes those are so subtle early that you really need the clinical correlation. It's almost necessary in those cases.
Just the other side of that spectrum, definitely for biopsied areas, but pictures are being taken for no reason, no biopsies being taken. I tend not to save those for your EMR because it's difficult. You don't biopsy them unless you know you're going to be following that lesion. But just to be taking pictures of lesions and without biopsies sometimes, or you're not going to follow it medically, legally sometimes.
Well, yeah, if you've got a picture of it and it looks like a melanoma and you don't biopsy it. I'm actually involved in a case right now, a medical legal expert, and the thing was getting bigger. The PA saw the patient and she didn't think it was really obviously melanoma, and it got a little bit bigger over the course of time. A clinician came in and saw the patient. They didn't, neither one of them thought it was melanoma. They did dermoscopy and everything. Finally, it develops a lymph node. Then they biopsy it and it's melanoma. And so they're trying to crucify them by looking at the pictures. So, if you're not going to biopsy it,
Well, sometimes the MA, they tell you got to take pictures of stuff. They're just like, and next thing you know, you got 10 pictures of one patient. Really, you don't need them. And theoretically, it's a medical legal risk. So
the same is true if you put microscopic photographs on the report.
there's
If you're a dermatologist looking at those things, they say, well, aren't you trained in dermatopathology and residency program? Didn't that show a melanoma there on that picture? The pathologist missed it, but can't you overread that too? And, Yeah, so there's ways you can get in trouble if you don't, if you see something, you have to make an interpretation of it. It's like a blood test result. It's in the chart, you didn't recognize, you didn't sign off on it. You know, that's open and shut.
There's an article in JAD about this, about imaging and dermatology, whether it's clinical or passive. It's not just passive sharing of information. That's a document, it's a medical document of a patient that requires interpretation and regardless. So you're like I was saying, you are held at the same standard as if that were your patient you were evaluated.
Good discussion. Okay, 36-year-old woman here with a 20-year history of this scaling and fissuring eruption on the left foot. This was symptomatic and seemed to worsen when she got her feet wet. She had a history of hyperhidrosis, and that also exacerbated the situation. She had been treated with topical steroids and antifungals before presentation, and there was no improvement with those.
And you know, the biopsy really correlates beautifully with the clinical. You saw these little pitted areas on her sole here and on the bottom of her toes. You see these correlate with the little pits, little dells that she's got there clinically. So they just shape biopsy, which is fine because this really isn't a deeper inflammatory infiltrate in this case. If you look carefully, once again, it's kind of hard to photograph these, but there's small gram-positive organisms sitting in the dells here. And these bacteria, they're in the Corynebacteria family, basically have they sort of just dissolve the keratin here. And so there's another example here. You can see them much better on this view. So this is pitted keratolysis, and it's induced by these bacteria here.
It was noted in the protocol that they would like some treatment suggestions if we can provide any, because she has tried topical antibiotics, clindamycin, erythromycin, benzoyl peroxide, mupirocin, and chlorhexidine, as well as oral doxy, urea cream, and glycopyrrolate wipes to control hyperhidrosis, and she's still battling this. So if there's any suggestions we can pass along, I think it was mentioned yesterday to maybe try a different oral antibiotic, but any other idea?
And maybe even, you know, the other thing is sometimes it's hard to stop acral sweating, and I don't know what kind of shoes she's wearing too. These bacteria can get into the actual leather, and so she may just be getting reinfected over and over again. But you may have to use a systemic anti-sweating agent like Robinol, which works really well for this. Electrophoresis is another thing you can ionophoresis is another thing you can do for this in some cases. But I would probably put her on some Robinol and continue some of the topical antibiotics, and then make sure and get her some new shoes, socks, and make sure that whole thing is taken care of.
Okay, next case. This is a 32-year-old man with 4-year history of pink papules and nodules on the forehead, who noticed similar eruption on the cheeks, the nose, perioral, ears, neck, chest, back, arms, legs. So pretty much just widespread and diffuse indurated plaques and nodules, and developed a leonine appearance on the face. Did not have any lymphadenopathy.
He was actually a patient of Dr. Rossian, who's a former resident of ours at UT Southwestern, who's actually practicing in Odessa. I think this guy may have been a Mexican immigrant, perhaps, I'm not sure. But it shows beautiful example. Again, this granulomatous inflammatory infiltrate here. You see it at low power. These cells are quite pale because they have foamy cytoplasm, and as you go to higher magnification, again, lymphocytes, these histiocytes here, notice the sparing of the papillodermis grin zone, a couple of plasma cells that infiltrate well. So again, that granulose inflammation. And this is the fight vein, which just demonstrates these numerate organisms, so-called Virchow cells, named after Professor Virchow, who was at the Charity Hospital in Paris a number of years ago. And that shows multivascular Hansen's disease.
He underwent treatment with ROM therapy, right? Rifampicin, ofloxacin, and minocycline. And after starting treatment, developed ulcerated plaques on the legs, which was thought to represent Lucio's phenomenon, although it wasn't biopsied at that point.
I think that's a good point, too. I mean, if you're going to treat Hansen's, I probably wouldn't just do that without getting maybe an expert infectious disease guy involved in this treatment patient, because you really want to avoid this. This could have been maybe avoided if they put them on thalidomide or something first, perhaps. Those are pretty nasty ulcers, and you know, that's kind of an unfortunate consequence that probably could have been avoided.
Case number 53 is a 42-year-old man, an immigrant from Honduras, who had a 1-month history of fevers, night sweats, and myalgia. He did have a history of pulmonary tuberculosis as well as MDA5 type of dermatomyositis. We don't know specifically what immunosuppression he might have been on for that treatment, but had that medical history. He had been treated for the TB with RIPE therapy, but did not tolerate due to GI side effects, and then developed a hyperpigmented and fluctuant plaque on the left hand and wrist, which was painful, and developed a purulent drainage.
Any of the presenters here from this case, would you like to make some comments?
The inpatient consult over at Oshner, and they called us mainly for these kind of fluctuant draining nodules on his fingers. Given his past history and then the clinical appearance, we were suspicious for infectious etiology. And then you can see like the hyperpigmented kind of patches on the arm with like the sporotrichoid kind of like spread. We were highly suspicious for cutaneous TB. So.
That's great.
Well, in symptom histology is sort of subtle. It's got a couple of different areas we'll show, but you can see that there's this inflammation down here, granulomatous inflammation. There's some degeneration of collagen, so perhaps this is undergoing some tuberculoid granulomatous change there. Higher magnification, you can see these histiocytes, and notice that they're not the same pattern we saw with the Coxey case earlier, the separative granulomatous pattern. This is more of kind of a, I guess this is almost quasi-tuberculoid pattern here. And then another area, we've got these multinucleated cells here, perhaps some degenerated collagen. And then I think the reason sort of maybe felt fluctuant is that the fat was involved here, and you can see that it's degenerated. So this fat is basically necrotic, and the dermis underneath here too is somewhat degenerated. And then we have special stains that demonstrated some acid-fast bacilli, quite a few actually in here, which is, so this certainly would be atypical or mycobacterial infection. The length of these organisms is sort of what you're supposed to see with TB. I don't know that I would just call it TB if I saw this, but I would just say it was positive. And then obviously the cultures and others would confirm the diagnosis.
Yeah, he did have cultures as well as PCR studies that confirmed Mycobacterium tuberculosis. And it sounds like from the protocol that he has had quite a complicated course with diffuse miliary tuberculosis and just a lot of cardiopulmonary complications despite treatment. So he's, as far as the end of the protocol, was still hospitalized and suffering complication.
One of the problems we had and still have in some cases, at least for the immunocompromised patients, especially HIV positive, was multi-drug resistant TB. And I presume was sensitive to the usual TB drugs that were they able to make sure that could respond to the medications. And I would presume is dermatomyositis is probably the thing that triggered this deal and caused it to get as out of control as much as it has.
Yeah, the treatment that he was started on more recently was ethambutol, moxifloxacin, and rifampin.
Yeah, MDA5 dermatomyositis is histologically of all the subtypes of dermatomyositis is where you're most likely to see a vasculopathy and has some specific cutaneous manifestations, oftentimes punched out ulcers overlying the interphalangeal joints. And sometimes you can get swelling like that, but a nice job really not falling for that and, noticing that there was something unusual about that clinical presentation and biopsy.
Okay, our next case, number 54, another hand presentation. This is a 40-year-old man this time who had a 3-month history of a red, painful, swollen plaque on the right dorsal aspect of the hand. And what we're seeing here in the photograph is a wound from a prior surgical incision that was meant to be therapeutic, but the patient has a history of being an avid diver and presented as this was progressing, despite surgical intervention, presented for dermatology evaluation.
Yeah, I've had experience over the years with hand surgeons and inflammatory dermatoses on the hand, and it's sort of like a train wreck. They don't understand inflammatory skin diseases. They'll go like everything is surgical. We've seen them going into debridements and amputations for pyoderma gangrenosum, seeing amputations for verrucous herpes virus infections on the hand. And so beware of having hand surgeons deal with things like this, because they end up causing problems. And Carlos is going to tell us a bit more about the history that really caused this to kind of get out of control. But she shows this very diffuse inflammatory infiltrate. Again, lots of suppuration here. There's some granulomatous inflammation, degeneration of collagen bundles in here as well, but largely suppuration. And we sort of tend to think of AFB infections as giving you a granulomatous reaction like the last one, but we see a lot of patients in the old days of HIV infection where they would get pustules and abscesses that were within avium that were due to AFB. And just look at the way too many tumors to count AFB in this specimen. And so this one, I think, was an mammary, I believe, that grew out here. But tell us what the good old hand surgeons did to this guy's infection.
It was M. marinum, but we figured that out with PCR. So this is actually a surgeon, the patient, who developed this recently from diving, probably. And I know he's an avid diver. And, you know, the hand surgeons have been working on him for, I don't know, at this point, a few weeks, up to a month. Debriding, going in, opening everything up, just basically seeding the whole area with atypical bacteria, cutting tendons. He's a surgeon, the patient. He has some weakness in that hand. So, you know, I like this case because it's not uncommon as a dermatologist where we see, like Clay had mentioned, things like erythema levatum diutinum on the hand that's infectious, right? This atypical mycobacteria is bacterial, but it's being treated wrong. It's getting out of hand. PG, the sweets of the dorsum of the hand, things like this. They're going to amputate or worse, you know. And we get there, and we're lucky to kind of like stop that bad cycle in which it's progressing, long-term issues. And then theoretical amputation in some cases, which I remember a case even with Tony, when we were residents, guy had PG, the dorsum hand. They called us because they wanted to amputate the hand. And so it's very rewarding as a dermatologist to be able to have that differential diagnosis in order to kind of make sure that there's a right approach, or at least we're thinking outside the box, right? Not just, oh, it's just positive, MRSA, or whatever nonsense secondary. Yeah, so
And nothing against them, but they don't get trained in inflammatory
that's why
stuff.
I'm saying.
Nothing.
We
You
get
know?
a differential. It's exactly what I'm saying. We have a differential, like we mentioned, that they're not trained in, and I think this happens commonly more than we'd like to see it. But in the end, he did get appropriate treatment. He's working. I haven't talked to him, but I know he's working. So, and I haven't heard from him, so I'm assuming things are good. But so it was a good turnout. The only thing is, I know they messed up his tendons in his hand, and I don't know how that will be long run, but he can work. So
It often amazes me how long non-dermatologists try to treat medical conditions where there's a clear dermatologic component before they refer patients to us. And for you, I think you mentioned that he was never referred to you. Like he somehow, because he's a physician. So it was informal. But otherwise, the surgeon may have still been trying to do all of this by him or herself.
Well, the fact that he's a surgeon is probably why he went to another surgical colleague. Hey, you got this in my hand, you fix it up. You know, just like the veterinarian decided he's going to freeze his own melanoma. You know, so the old statement of a doctor that has himself as a patient as a fool for a patient. So you don't want to do that. You should have gone to see you from the beginning, not just by texting.
Another thing with these atypical mycobacterium, sometimes they don't grow. Sometimes we see them unstained. So it's very important to push to get those PCR. I mean, like, you should get the right clinically.
Yeah, that's a good point. We send
I
ours to
send it to
University
University of Washington.
Washington is.
It's very easy to do. I can email you all the form. It's really easy to do. You can send it either on a fresh specimen or on a done biopsy.
Well, the other thing people that we forget about as derms also, we forget about imaging. So we don't do x-rays. It might have been valuable to get an x-ray to see what this thing looked like, or that MRI that was done on the kid's back of his head. Or we don't think about skin testing either. You know, and now we have serologic testing that you could do in addition to PCR. So sometimes do a skin test for like a tuberculous positive, even though I have AFP, it's weakly positive. So that can kind of tip you off too. So just don't forget those tests also.
I don't know, we happen to see a lot of those here, I guess, with all the sailors and fishermen. And what I always tell the residents is if you have a biopsy and you don't see anything on stains, that doesn't mean it's negative, especially in an immunocompetent patient. And so sometimes when they have plaque, they may have to get excised and there may be one little bitty focus. So a negative stain doesn't rule it out. The other thing too is if the patient's insurance makes them go to like one of these labs, like not a hospital lab, you have to, I won't say names, you have to make sure that you put on the slip at room temperature, not only, 37, but at room temperature too, because then it won't grow. And the atypicals usually grow very fast. They're the first ones to grow.
Great points.
Our next case, number 55, is a 45-year-old man who had a diagnosis of HIV, was off of his heart therapy, developed a 3-week history of an eruption of indurated erythematous papules on the legs, trunk, face, and groin.
Any of the presenters want to discuss this case from New Orleans?
Yeah, this was a patient we saw in clinic at Ochsner. The patient had been seen either earlier that day or the day before in ID clinic. And so we were suspicious for syphilis because the RPR titers were high. So
yeah, the positive RPR noted.
Yeah, and if you ever get a patient diagnosed with syphilis, I guess here you knew is HIV positive. You have to always go back and check them for HIV because it's a sign that they've been unsafe sex, and that can often be a presenting sign. The pathology is classic. It shows this superficial deep psoriasiform lichenoid infiltrate with plasma cells and some granulomatous inflammation here. And Dr. Mim, again, in honor of him, used to talk about the granulomas that get formed in syphilis are, quote, fecally kind of granulomas. They're not really well-formed granulomas, and that's kind of true. But you see all plasma cells in here, just too numerous to count. And that is one of the truisms of syphilis pathology. It usually will have some plasma cells in there somewhere. So we didn't have the special stain on this, but I presume it was probably positive. And of course, the RPR was positive as well, confirming the diagnosis.
The protocol indicated that the IHC stain was negative, and so that was kind of a little bit troubling, but they ended up settling on a diagnosis of syphilis with clinical correlation despite that negative stain, which I think is appropriate.
Yeah, we see a fair number of those that are negative when they have positive RPR. I just saw one the other day. So it's not perfect. When it's positive, it's great, but if it's negative, then rule it out.
Okay, our last case, also from New Orleans. This is a 50-year-old African-American woman with end-stage renal disease who had been treated with a renal transplant. She was on prednisone and tacrolimus, who was having transplant rejection and was also on hemodialysis. She developed a 1-month history of a pustular eruption on the face, as well as a crusted ulcer on the upper lip. She had a few pustules on the upper body, but mostly centralized on the face.
Any of the presenters here for this case as well?
I was able to very astutely put first on my differential, rule out disseminated histoplasmosis.
Well, it's interesting, the story that you had. I had a case sort of analogous to this many years ago. It was an HIV positive patient that had been in the hospital and had blood cultures done. And they came back as positive for staph. And he had widespread lesions, some of them abscesses and whatnot. And so they could have been staph. So they put him on anti-staph treatment and sent him home. And then the blood culture came back about a week later positive for sporo. And he had widespread disseminated sporo and staph, and he was HIV positive, low CD4 count. finally got him back in. He'd had a biopsy done that was interpreted as just abscess. They had a GMS stain, and because it's so many organisms in there, they could recognize that that was sporo. And eventually he got put on amphotericin and all these other drugs. He never got better and eventually died from it. So same kind of story. Sometimes people get sent out and they have positive blood cultures, and you need to always watch those, make sure you don't miss them. But here's her, which is very diffuse infiltrate. All these are histiocytes here. And it's got higher magnification, just loaded with organisms. So just a massive, load of these organisms. It's amazing. And so, different diagnosis of these parasitized histiocytes includes this, and rhinoscleroma and donovaniasis and a few other things that can do this penicillium. But this is really classic for histo. And here's the GMS stain, which is strongly positive.
Yeah, and I think one kind of interesting aspect is the oral ulceration, which is typical of histo more so than other disseminated fungal organisms. So that's a good clue to potential histo infection.
Histo can be subtle clinically and histologically. I've seen cases that have looked like folliculitis or like rosacea, especially in immunocompromised patients. And I've seen biopsies that look sort of like leukocytoclastic vasculitis, as the organisms can stimulate leukocytoclasia, and they can also have a neutrophilic infiltrate. So this patient, anybody could diagnose that basically, but sometimes it's not so easy, and you have to think about other things clinically. We talked about that yesterday also. Crypto, other things can even atypical mycobacterial immunocompromised patient can be just about anything.
Yeah, so any rash in an immunocompromised patient, especially if they have a fever, you just biopsy, no matter how benign it looks like. I'll never forget that one time when earlier in my career, when I was on hospital consults, we saw like an 80-year-old guy who had been having fatigue for a few weeks, intermittent fevers, was admitted for a workup. He had some lymphoproliferative disorder. It wasn't subcutaneous panniculitis-like T-cell lymphoma, some other one that was treated with an immunomodulatory agent. So he was on cyclosporin. And we saw him, and all he had was like a little bit of edema on the forearms, no inflammation at all. And, we sort of shrugged it off that day and said, I think it's, maybe just dependent edema for whatever reason. If it doesn't go away tomorrow, we'll biopsy. Didn't go away. We biopsied it. It was disseminated protothecosis, and he died from it. I mean, it was bad. So, that's just one of those hard lessons where don't think too much, just biopsy, get some objective.
We had a very similar case way many years ago. You were probably a diapers when saw that case, but similar thing. It looked like cellulitis. We kept biopsying, culturing, everything negative. And the guy down the hall from us, this is back when I was still in faculty at UT Southwestern, that's how long ago it was. He was a clinical pathologist. He said, well, let me take this and I'll take a smear of it. And he took the smear and he went and put an immunofluorescent stain on there. It lit up for histoantigen. And that's the only way that we were able to make the diagnosis. That was even pre-serologic histo testing at the time. And it ultimately treated patients, a renal transplant patient, and she did okay with it, but it just took a long time to make the diagnosis. And to get to your point about AFB infections, we had these people a few years ago that were getting these manicures, pedicures, and they were in these, they put their feet in these baths and they wouldn't sterilize the water. And we had an epidemic, a small epidemic of AFB infections in the Dallas-Fort Worth area. They're getting these abscesses on the lower feet. I had a biopsy 5 times, culture 5 times before finally something grew out. So you really have to be persistent in order to make the diagnosis sometimes.
Right. But John actually called me. I can just
We'll let Carlos have the microphone and burn up the next 30 minutes.
start singing. So if you're on call on a weekend and the patient's sick, they're immunocompromised, and they've got these ulcerated umbilicated lesions, just roll it on a slide, let it air dry, and run it down to the lab. And you don't have to wait for a culture or a special stain. You'll have your diagnosis in 10 minutes. So it's easy to do, and you just have to think about it.
Great. Well, thank you guys for attending today. And we have cases, as you saw, coming in from Canada and Detroit, New York. So people welcome us to the cases. We have a little presentation too to do at the end. So
So we have a few closing remarks. We want to acknowledge every year we recognize two cases that stand out, and one is usually the most educational case, and then one that's the most esoteric. And for the most educational case, we selected the case from New Orleans of the patient with the multiple presentations of neutrophilic eruptions, the one with the EED that evolved into a more sweets-like and ultimately a linear IgA presentation. And then for the most esoteric, we decided
That MF case
Yes,
with
the
the
MF
lymphangiomatous morphology.
mycosis fungoides with a cobblestone edematous appearance. So those are our standouts. These are all amazing cases, and I really want to thank everybody for their contributions.